Well, good morning, everybody. I am so excited that you were able to join us, both those who are in person and those who are online, to our Bridges Transition Conference. This is an exciting time to be back in person for some of us. This is a conference that we've been holding for providers and families for quite a while at Children's, but related to COVID, we had a downturn where we had to do this virtual. So it's nice to be back in person. As we start, I wanted just to share one quick slide with you right here. And this is a picture of the Roberto Clemente Bridge. And we know that Pittsburgh is full of bridges. And I want to show this because I think that as we start this conference, it's always important to think about our why. Why are we here today? And I know a lot of us probably came for different reasons. For some of us as providers, we may be really feeling the need to learn more, to think about how can we do a better job helping our young adults move into the adult world. For some of us as families and as self-advocates, we just want to learn how to navigate this road. But I want us to focus our why thinking about this bridge. And we will talk about the importance of bridges probably throughout this conference, of how do we build a good bridge? How do we start this journey and go on this journey from pediatric to adult care? But I want to start with a story. I was on this bridge about 3 years ago during the summer of 2020, in the midst of COVID, right? And on that bridge, there were a couple thousand people. And the reason why we were on that bridge is that there was this need to stand up against the murder of a young man, George Floyd. And one of the things that was stated over and over again was this statement: no justice, no peace. No justice, no peace. And I want us to use that as a framework to think about why are we here today. So when I think about the word justice, a theologian, Cornel West, said that justice is what love looks like in public. So how do we love people in public? What does it look like to think about equity, to care for everybody in our community? In peace comes from a more ancient word, a Hebrew word of shalom. And shalom doesn't mean the absence of conflict. Shalom means wholeness. And so when we think about this idea of equity and wholeness as a community, we have to think about how do we care for everybody? How do we include and value everybody? And that is really what transition is all about. Transition is the recognition that as young adults, we all have different challenges that are interacting with our lives. Challenges that can lead to the inability to get to adulthood in a successful way. And what we're talking about is how do we build a bridge so that every single one of our young adults moves into adulthood in the way in which the fullness of who they are can be expressed. So when we think about transition, the importance of it is valuing every single person in the room and thinking about how can we make sure that they successfully get there. And so as we think about our why for today, while we're going to be talking about all these different pieces, these technical things, really should center on how do we value our young adults and we make sure that they are the ones lifted up, centered, and think about how they can successfully show who they are as an adult. So I just want to be able to encourage you and say that is going to be our why today. How do we center our young adults and value them? Now we have the opportunity to hand it over to Arvind to think about, our welcome for this conference, and we have a special guest who is going to be welcoming us all and just inviting us into this time at Children's Hospital.
Thanks, Andy, for kicking us off. And I'm Arvind Hoskapal. I'm a cardiologist. I take care of adults with congenital heart disease. So this conference is near and dear to my heart, no pun intended. But I have the great pleasure of introducing our next speaker, who's going to be delivering some opening remarks. It's Dr. Diane Hupp. She's the president of the UPMC Children's Hospital of Pittsburgh. And prior to this, she's worked for more than 30 years at the Children's Hospital, and she's synonymous with what our Children's Hospital stands for. One of my favorite memories of Diane is when the pandemic hit. I was going to go get my N95 mask, and she was there, boots on the ground. She was a chief nursing officer back then, handing out masks and being there in the front lines, leading us through the pandemic. So with no further ado, Diane Hupp.
Thank you very much. And it is good to say that we're well beyond those pandemic days. They were something. But as Dr. Arvind said, my name's Diane Hupp, and I have the privilege of serving as the president here at UPMC Children's Hospital of Pittsburgh. I have spent my career here, and when I think back, a majority of those years, I'm still a nurse, I'll always be a nurse, but as a young nurse, I do have fond memories of our young adults that needed transitioned. And I want to start with a huge thank you to these two physicians here, Dr. McCormick, Dr. Arvind Hoskapal. We thank you for your purpose and your passion and getting us all together here. There are a lot of other individuals in this room who I know spend a lot of time, a lot of energy. I mean, I look at Bev only because Bev's one of the ones I've known for so long as a nurse herself. And from when I first met Bev, and this goes back decades, her purpose and passion is to help better transition. You know, she works in the transplant world, as many of you know, but is to help transition our young adults to continue to have a seamless transition in their healthcare and their journey of life. So in my years here, just a few brief messages. First and foremost, a huge welcome. You know, beyond my thanks and gratitude for taking out your Saturday morning, I want to give you a heartfelt welcome. Whether you're a patient, whether you're a provider, a guest, an advocate for this important work, we thank you. This takes time, it takes dedication, and it takes, I believe, a different way of thinking. Children's Hospital mission has always been to take care of all. Our mission is to take care of not just infants and babies and young children, but young adults and even adults that aren't so young. When we think of young adults, we think of those maybe in their upper teens and 20s. We know that Children's Hospital takes excellent care of adults for some special diagnosis. But we also know that there comes a point in time where it's right to begin transitions. I love the picture of the bridge. When I look at the bridge and when I think of the word bridge, I think of connections. I think of endings and I think of beginnings and all of what's in between. And I'm sure today, those here and our experts that are going to speak are going to speak to some of the endings, the challenges, and the challenges with new beginnings. We all go through changes in our life and transitions in our life, whether they're personal or whether they're professional. They all bring about challenges, but they also bring about, I believe, a level of hope and opening new doors. So my hope today is that, number one, that we're increasing the awareness of this very important work that each of you do every day. I think number two, I'm most certain that you'll discuss a lot of the challenges. And finally, number three is, with those challenges, how can we work through them? How can we resolve them? Our job here, whatever role you play at Children's Hospital of Pittsburgh, is to improve the lives of our children, our young adults, and our families. We know that to do that, it takes all of us. It's a multidisciplinary approach. When I look in the room today, and I not only see some patients and families, but I see physicians, nurses, social workers, support staff, different providers. It takes every one of us and a superior multidisciplinary team to make that happen. I do believe here at Children's that we do a good job at transitioning. We've been working on it, but the opportunity is still there to get us up to the great job every time for every patient that needs transitioned. And that's really why we're here today. So our commitment to you on behalf of Children's Hospital is that we're here to support. I, as the hospital leader, certainly want to support this important initiative. And that's why when asked to say, can you take a few minutes just to come to give a warm welcome, I said, for sure, it is important work. You are all valued, you're appreciated, and thank you for your focus. I want to end by saying, if there's anything I can personally do to help as you go through your morning and you end your morning, and I'm sure there'll be some next steps and some action items and focus steps. If there's anything I can personally do to help to bring this to the next level and to reach the next level with our children, our young adults, and our families, to get them to feeling really good about the transitions, I know that our leaders here today will let me know, because I want to help in that way. So with that, I wish you a wonderful morning. Enjoy yourselves. Networking is always part of one of the best things when you get to conferences. We have a nice group here in the room. I thank all of those of you. I know there's a large crowd that's dialed in virtually, and just hope you enjoy yourselves this morning. And thanks for giving me the opportunity to say hello and thank you and offer you a warm welcome. Enjoy. Thanks.
Well, I'm excited for us to be able to get started on this journey together around transition. And Dr. Hupp, thank you for those kind and warming words. And I love that image of a starting point and an ending point with transition. When we think about transition, transition is the purposeful and planned process to move to adulthood. And so we are going to have this first session, and it's going to have three different components where we're going to think about kind of the core elements of successful transition. But really what we're looking at is different perspectives from stakeholders. We're going to have a talk from Bev Kosmak, who was already introduced by Diane, who is a great champion of transition here at Children's Hospital. I know Bev for a long time working on the transition task force here, but she's actually a national leader as well, as she chairs the transition task force for the American Society of Transplant, which is an amazing amount of work. And they recently just published guidelines about how they are nationally going to think about transition for individuals with transplants. So we get to hear from her great experience as a pediatric perspective, but we also have the other side. If we had that being the on-ramp, we have the off-ramp too, as we have Dr. Kristen Ehrenberger here from the Progressive Evaluation and Referral Center, which is a landing place clinic in the adult world for individuals with complex healthcare needs from childhood moving into adulthood. And then finally, we're going to round it out by having a special guest who is going to be talking about his own experience walking through the healthcare system. And Arvin's going to be introducing him a little bit later. But I'm going to first invite Bev to the stage, followed by Kristen, to talk about what does transition look like from these different stakeholder perspectives.
Thank you for that introduction, and thanks for inviting me to speak today. After your beautiful introduction, Andy, about the bridges, I'd like to kind of start again and reframe my talk. But I'm going to start with a little story myself, and that just in getting involved in transition, I think I owe that from, I became involved because of my patients and because of my families, and I was pulled into it. So I remember at the time when we started out in small bowel transplant, which was a very rare procedure with, in the early days, a survival of barely 20% in the first year. And a mother said to me, "How am I going to toilet train my child?" And I'm thinking, well, we're hoping we'll get him to 2 or 3. And then this patient will get to be that old. And then the next question would be, can my child go to school? And I never thought about that. Like, well, maybe they can, but let's see what we can do about trying to make the school work for them. So they pulled me into helping them get involved in school and preparing them for school and understanding about their condition and that they had a transplant and they have to take meds twice a day. And then it would lead into my favorite one was, Bev, I need for you to write a letter for my doctor, and they wanted it for the school system as well as for some other things. And I said, yeah, what would that be on? And she said, well, my daughter can't drive a car. And I said, why would that be? And she said, well, she has an intestine transplant. And I said, well, good luck, good try, Mom. It is a scary time to have a young adult, a teen learn how to drive, but no, she's fine, she can drive a car. And we went from that with some of my patients to wanting to do a semester in Japan, and how can we work that? So I have been engaged, and I really am passionate about transition, but I owe it all to my patients and families who've pulled me along with them. And I've learned how our team can help them and support them in doing everything that they want to do as young adults and give them all those opportunities. So with that said, I would like to be giving you today a practical approach. So the providers in here, hopefully you'll come out from this with how can I establish a program? And I think the most important thing to do is do something. Talk about it a lot, talk to your patients and your families, and do something. I'll be talking about a few interventions, those that are supported by the GOT Transition Group. And then at the end, I'm going to briefly talk about our program and what we've accomplished. There's not a lot of time to do a review of literature, but I do really want to talk about this one paper that I think applies to everybody who's transitioning patients. And this is done by a nephrology group, Dr. Quinn et al. And they, this paper really guided our program in developing our transition program called My Path, as well as the GOT Transition Guidelines. It's a qualitative assessment, and it looked at renal transplant patients who were transferred to adult care. After they were transferred, they participated in a qualitative study, and they grouped the patients by if their graft was stable or unstable. So obviously with stable function, their kidneys were working well, they were coming to clinic, they were getting their labs. And the unstable group was a group of patients that perhaps were lost to follow-up, were missing labs. They had a GFR that was greater than a 50% decrease during that period of transition, those sorts of things. So when they looked at the qualitative assessment of these two groups, the patients who were stable with their kidney graft had a greater confidence in their adult team. And this was 70% to 40% in assessing their outcomes. And the themes that came up were those of trust. They felt they had a personal referral to that adult person, and they were aware that the pediatric and the adult team had a relationship. And they saw that there was steady communication between both teams. And unfortunately, the unstable group felt that there was a lack of understanding of even why their care was being transitioned. They were frustrated with the process, and they felt abandoned. Themes that, if you look in the literature, you hear a lot about this from the teens and the young adults. So Dr. Quinn and her group felt that confidence in and connection to this entire healthcare team could be predictive factors in helping them adapt to adult care. And another important thing is, although we're all about knowledge and skill building, perhaps the role of the interdependence between the teams and that trust in going from pediatric to adult care is perhaps the key to all of this. So in considering all of our role changes, for those of you who are teens and young adults in here and the providers, we all go through a role change with this, and I find this to be very difficult. So we go from a pediatric provider having the major responsibility to becoming a resource, the parents who are the primary caregivers now becoming a consultant in care, and think of how difficult that is for some of you who are parents in here, stepping back. And most importantly, the youth who's passive in their care, receiving care all these years, has to develop into being the supervisor or the CEO of their care. This graphic was designed by the prior Good to Go program at Sick Kids in Toronto. And I use this all the time when I talk to my families to explain to them what our goal is. And with respect to the Good to Go program, I'd also like to add the adult provider on this, because transition doesn't end at transfer, but it's a continuation into adult care as that emerging adult matures into their executive functioning skills. And these are things that Dr. Ehrenberger is going to talk about next. So for all of you in the audience, I think many of you may already know about the fabulous website called GOT Transition. It's a federally funded national resource center on healthcare transition with the aim to improve transition from pediatric to adult healthcare through the use of evidence-driven strategies. And there are many resources here. If you are just starting to build a program, look at this first. There's no reason to reinvent the wheel. Use their tools, adapt them to your practice. They have a wonderful family toolkit that I would advise all the families in here and listening on the line to download. It's about 30 pages. It has questionnaires. It has ways to think through the algorithm of helping your child take on more responsibility. And for the young adult and the teen, it helps them think through what skills they need. So for instance, this is an example of what GOT Transition advises the youth to be doing through their years, questions they should be asking that their provider, and also skills that they may be seeing that they can do. There's a similar one for the parent caregiver. Also, there are many resources on the site for youth with developmental or intellectual disabilities to help them engage in their care to the best of their ability. And one tool that I really like a lot is this charting the life course that a parent can do with their child, or you can do as an interview when you're doing your transition session. And it helps the parent and teen decide together what decision-making processes are needed. So there are 6 different areas, daily living and healthy living, you see here. And then the youth can decide with the parent, depending on their level, their cognitive level, if no extra support is needed in helping them transition, or if they need some support, or if they're fine and they can do it themselves. So within these 6 areas, there's some things they could probably do capably, but others that they might need help with. So the foundation of GOT Transition is the 6 core elements, which help the healthcare team develop the timeline for transition and provides recommendations and strategies. So I'm going to review each of these steps, pointing out strategies for providers who are starting a program, and also giving families and the teens some ideas of what they can do. There are so many things to be done within this framework of the 6 core elements. And I would strongly recommend that you look at the handbook that's on their website. And it's very comprehensive, and you think, I can never do that. I don't have the resources or the time, but you can do bits of it. They'll give you bullet points and think, the best advice I got from Dr. Miriam Kaufman out of Sick Kids in Toronto, who built the Good to Go program, was just do something and talk about it all the time. And I always think about that, because the more you talk about it, the more you get people interested. And I can say when I first started talking about it in my practice, usually the moms would burst into tears, the kids would curl up in a ball like I'm not going anywhere, and then they wouldn't collaborate with us. But now, because we talk about it constantly, from the time I evaluate a 6-month-old baby with biliary atresia to whenever we get them over to the adult side, it's part of their care, and they're seeing it as part of their care. So the first core element is developing a transition and care policy. So this formalizes the approach. And so you think, oh, policy development, this kind of sounds boring, but I have found this to be really important because it validates your program. You're talking about what you need to do and how you're going to do it in very simple terms. The youth should be able to read this and say, oh, that's me. And now they're going to help me do this and this and this. And the parent should be able to read it and say, we have support from our team to help us do this process, which is challenging and scary at the beginning. It also helps to define what your team will do and what each of their roles will be. And in doing that, you try to have definite plans within your department that everybody's doing the same thing. Tracking and monitoring is a bit of the business part of it to set up at the beginning. So you need to establish the criteria and the process for doing this, and it'll be different with every division, every department, maybe within a department. Like for us, this is a little different between liver, what I do in intestine, and what the kidney program is going to be doing. You need to determine what tracking information is important for you to follow. I always think to keep it simple, you don't need everything. You need what's most critical in your practice. A little bit about the patient's clinical status, and most important, their psychosocial issues and concerns. And I could go into this for another full presentation about how the youth should be presenting themselves. What name do they like to be called? What's their favorite name to be called? What we do something in our meet and greet where we ask the youth to talk about something about themselves that is not medical. And I can tell you that's the best part of our assessment, and it's how you get to know them a little bit better. And then probably one of the most difficult parts of this for the providers is, how do we monitor our progress? So there are a variety of checklists and templates on the GOT Transition site to help you work on this, but you have to monitor where you're going through the system and how well you're doing, so that every stakeholder in this knows where we're at. The main thing is to just get an outline for what you do, and then work with your EMR and your team for how we can effectively get all that information passed through. So for right now in our program, we're enrolling everybody at the age of 13 into MyPath. We have a structured program. We still have plenty of work to do, but we're making a lot of progress in our educational and skill building part. And then when they get to 18, we prioritize them into our fast track. There's lots of challenges. That's, again, another talk, but we take those as they come. And right now, I'm keeping track on a flow sheet, but hopefully this will be involved with the EMR, particularly when we transfer over to Epic in the future. The next core element is transition readiness. This GOT transition recommends that you look at that you use a standardized tool that's going to assess the skills of the youth. There are lots of different tools out there that are validated. So I think you choose what's best for you, what you think you can get through in a clinic session. And you use this so that you understand where your patient is at. And it also helps the youth and the caregivers know, I'll have a parent that's saying, I thought they could fill up their med container, whereas the teen is telling me, I struggle with that. I really still need help with doing it. So in our department, we're using the pediatric transition portal at AST. This is on for all solid organ transplants, but I would recommend that you look at this on our website from AST, because we created it as a template and it really could be adapted to any chronic condition. The main questions are there. We have 11 domains of functioning, and we do a qualitative assessment as well as a checklist to assess outcomes. Transition planning is the busiest of the core elements. This is when they're hitting that 18 years of age or your top age, and when you're trying to get them ready to go over. So you need a routine readiness assessment. You need to update their goals. We start a medical summary, and you can add on to that every time you see them. You have to determine if there are any decision-making supports that are needed with any legal documents that might be needed on the adult side. One of the more difficult things is to confirm resources, because it's a bit different on the adult side. I know that Dr. Ehrenberger will talk about how plugged in everyone is within her group, which is incredible. But I transfer to a lot of centers that have only transplant hepatology or only transplant GI, and I don't have a social worker and psych and the other parts of the multidisciplinary team. And sometimes after the age of 18 or 21, it becomes incredibly difficult to get resources. We need the use consent for release of medical records and then plan for timing. So I would say that during this planning stage, what has helped us the most is that we have totally redesigned our annual transplant clinic, so that now, rather than just let's look at how you're doing from the transplant standpoint, we're looking at various dimensions of our patient's health. So our patients participate in individual sessions with each of the providers that you see here. I do a separate session on transition with them, but they also meet with the other providers who talk about transition. We're on the same page, and then in talking about transition and how we're going to do that. And then in addition, we have meeting every Friday where we review the patients we saw and we reach a consensus about where they are in transition and how we can get them to adult care. This is just a graphic of our overall plan. So we do a readiness assessment, and then it's assessment, intervening, and reassess as they go from 13 to 18 or so. We see them in clinic. We have various learning modules. This is under development, but we have a good start. We work on skill building. How do I make an appointment? How do I call in for refills or do that online? We have peer support through our transplant camp and also through our adolescent group Encore, with the patients are encouraged to attend. They have quarterly meetings. And then when they get to be 18, we prioritize, as I said, in our fast track program. And then for transfer of care, you want to make sure that at that point, your patient is stable and ready for transfer. And for the teens, you have to be sure that you really feel that you're ready. You're going to be a little bit nervous. It's a change, but as long as you feel that you're ready to do the basics, we can get you over there with support. Transfer checklists are very important during this time to make sure you do everything so that the adult side has all the tools they need to help make this successful. There are, again, various templates on this in GOT Transition. And then communication with the adult team is really important. We have a routine meeting the last Wednesday of every month and go through all of our patients that are on the queue. And as I mentioned earlier, we have our virtual meet and greet. And then finally, we're at transfer completion. And this sounds silly to say, but you need to confirm that they transferred and actually were at the first appointment. We have a member of our team that goes to that first adult appointment for our patients that are on the adult side. But when they go to an outside center, we make a phone call and we are sure that they attended. And then you want to continue to nurture that collaborative relationship with the adult team. So now in pediatrics, we become a consultant, but we want to obtain feedback from how we can do that better, and then assess the patient outcomes and all the stakeholder perspectives. So very briefly to conclude, I'd like to talk about some the overall results of our program. We've been doing this for about 3 years now, and I'm going to speak to the patients that we have sent over to the adult side through our program. So we have outcomes data available for up to 2 years. The average is about a year. We've had 35 liver transplant patients who have gone to adult care within UPMC. A little more than half are male, and the mean age at transfer is 27, which I know sounds incredibly old, but we have a large population of metabolic patients who get transplanted at a later age, and we keep them for 3 years after surgery. And this also reflects the backlog of patients we had that needed to get to adult care. We had full participation of all 35 patients. They were involved in the MyPath sessions. They had a virtual meet and greet, and they all attended their first clinic appointment, and most with a support person. Almost all of them have had stable or baseline liver function tests with no significant comorbidities. Our adherence is quite good. This MLVI is a standard deviation of the tacrolimus level, which is our primary immunosuppressive med. The value you want to see is 2 or less. So over half of them had an MLVI of less than 2. We were pleased about that, with a mean of 1.75. Adherence with labs was roughly 70%. One area that we need to improve is about 70% attended their first clinic after the transfer. So this is at 12 months after transfer. We had some no-shows, which was upsetting. They should have at least called to reschedule, but we're working on that. The subjective comments of the coordinators are that most of them are maintaining routine contact and calling appropriately for what they need or if they have issues. The new onset comorbidities are minimal, so this was a very stable group. We did see 2 episodes of rejection due to non-adherence, and then some issues that you would also expect in an older patient, long-term immunosuppression, and as young adults with some hypertension, hyperlipidemia, and GI issues, which is mostly GERD. And we've had 3 pregnancies after transfer, which is I'm very happy about. We've had 2 live births with 2 little baby girls who are healthy, and we have another mom who will be delivering in November. And another really good advantage of this is that these patients are now going for preconception counseling with the maternal fetal program at McGee. So in conclusion, all the young adults in this group are medically stable, as I just showed. Most are communicating appropriately with their coordinator. However, we're starting to see some deficits in self-care, particularly with the labs and the follow-up, which really has to do with executive functioning as these young people are still in the emerging adult phase. And it affects their ability to fully plan and organize. So when you say get labs, they can say, sure, I'll get labs, but there are a lot of things to do to be able to get to sit in that chair to have your labs drawn on Thursday morning at 7:30, right? So in response to that, we're doing more targeted education on labs and follow-up during the transition session, and the adult side is also engaging more with frequent contact after transfer, reminder calls, and emails. So we're seeing that a partnership between the youth, the parents, the pediatric providers, and the adult providers through a structured program that supports this continued transition into adult care may promote stability and maintain healthy outcomes. We have a long way to go, but I think we have a good first start. So of course, the young adult perspective as transition is warranted. We just got funding to do a couple focus groups this summer, so I'm very excited about talking to the teens about their experience. And I'm hoping that through these discussions, that we see them reflecting that they have a confidence in our teams, a sense of trust, and effective communication and collaboration that's helping them succeed in the transition to the adult providers. Thank you.
All right. Welcome to Adultlandia, or how to prepare for the adult healthcare system. This morning, I'm going to discuss the who, when, and how of medical transition. 18 years old is an adult for insurance or billing purposes. So if you or your young person are already established with a family medicine practitioner or a med-peds physician, good news, you can continue to receive medical care at the same familiar office. If, however, you have enjoyed a relationship with a pediatrician for the last 18 to 21 years, it's time to find an adult provider. What kind of primary care clinician should you look for? If you are relatively healthy and have what are considered general medical conditions such as asthma, celiac disease, or constipation, you can probably see what's called a general internist at an internal medicine clinic, and maybe even the clinician that your parent sees. And depending on the severity of your condition, that person may be able to manage them for you without a specialist. For instance, hypothyroidism may not require an adult endocrinologist. However, someone with type 1 diabetes should still see endocrinology, and somebody with trisomy 21 should establish with the Adult Down Syndrome Center. Individuals with developmental disabilities may want to look for a savvy family medicine practitioner like Dr. Mary Nagwit, or someone who is trained in internal medicine and pediatrics, what we call med-peds for short, since doctors like Dr. Corey Tuchik have experience with both pediatric and adult conditions. Now, if you need more help with adolescent problems or finding an adult provider than your pediatrician is able to offer, I highly recommend the adolescent and young adult medicine clinics. They can work on adulting skills such as navigating the healthcare system or do things like menstrual regulation, and all up to the age of 26. So you could consider them like a rest stop on your way to Adultlandia, either temporarily as your PCP or as a consultant to your pediatrician. And clinicians, I'd like to let you know that you can also e-consult your colleagues, Drs. Jacqueline Rankin or Loretta Mateo, if you need help in this area. Another answer to the question of who might be the clinic that I direct, Dr. Alda Maria Gonzaga founded the Progressive Evaluation and Referral Center, or PERC Clinic, in 2006 as a counterpart to the Adolescent Bridges Clinic. But rather than handing off patients to other adult providers, she ended up keeping most of them. Dr. Reed Van Duzen joined her in 2008, and I came on 3 years ago. We are all med-peds trained and offer primary care to individuals with 2 or 3 of these admission criteria: childhood onset medical complexity, intellectual or developmental disability, and technology dependence. And by that, I don't mean that their cell phone is never out of their hand. I mean things like trachs, feeding tubes, mobility, and communication devices. No one is too complicated for us. Now, one of the perks of PERC is that we can schedule longer visits to make sure we have enough time to answer all of your questions. And if you happen to have found a PCP closer to where you live, but just wish that there was someone in Pittsburgh to help oversee some of the details, the good news is that PERC also provides care coordination, just like the complex care clinic does at Children's. You could see us once or twice a year via video to facilitate communication among specialists, troubleshoot durable medical equipment, while keeping a closer PCP for acute visits and flu shots. If for whatever reason PERC is not a good fit, we will find you another PCP. PERC is different from other primary care clinics. Because we take care of complicated patients, you can't just call to make an appointment. We do have an admissions process facilitated by our administrator to have a safe transfer of care. So in addition to meeting these 3 criteria, we do require doc-to-doc sign out, either a written transfer summary or else a short phone call. This should give an overview of the individual's medical journey. Maybe they had a lot of surgeries when they were an infant, but now they're doing great, and provide some best practices for working with them. So for instance, do we need to reserve a larger room to make sure there's space for a stretcher, or do we need to invite a translator? Can they sit quietly in the waiting room, or do they need to be roomed immediately? Are there triggering topics that we should avoid discussing in front of the young person? Should we plan to have a quick physical exam when we first meet them, and then let a caregiver take them out while we talk to the parent about the histories? Or are they capable of making any of their own decisions? And if not, who does make those decisions? These are the kinds of details that rarely make it into the typical office visit note, but if they are communicated with the adult provider, they set everybody up for success. Now, PERC requires a transfer summary, but it's actually a good idea for any transition of the young person if they have healthcare complexity. And here's a pro tip. You don't have to wait for the pediatrician to find time in their busy schedule to write one. A caregiver or even the patient themselves can write a first draft for their PCP to review. And don't feel like you have to get this all done at the 18-year well child check. It's possible to schedule a visit just to talk about transition, and there are billing codes for that. If you are interested in coming to PERC, once we get the transfer summary, I review it to make sure that the clinic is a good fit, and then I'll decide how long that first visit will be. I see patients in Oakland as well as in West Mifflin with a 1 to 3 month wait. Dr. Van Dusen sees patients in Oakland and at Turtle Creek, usually with a 6-month wait, and Dr. Gonzaga is no longer taking new patients. So this gets us back to the question of when. Every pediatric practice is different, so you'll have to ask both your PCP and your specialists when they expect you to start seeing an adult provider and whether they have a recommendation of whom you should see. Just as it is possible to come to Lawrenceville to see most or all of your doctors, many of the adult specialists in Oakland for UPMC are in Oakland and on the north side for AHN. Unfortunately, UPMC does not yet have patient navigators on the adult side, so it is a little more difficult to schedule multiple visits on the same day. Furthermore, the national guidelines at gottransition.org recommend changing providers when you're relatively healthy or stable. It's even harder, potentially unsafe, to go to a new PCP in the middle of a workup or after a prolonged hospital stay, because then that new provider has to learn all about you and also figure out what is going wrong. Please know that we're not able to write referrals or orders until we've seen you, but most pediatricians will continue to provide refills until you've established with a new PCP. And therefore, the best time to start looking for an adult provider is usually about the age of 18 to 21, just when you don't think that you need a doctor. And don't worry about changing all of your providers all at once. It might make sense to have a getting to know you visit with the new adult provider, even if you're not due for an annual exam, and then they can help you find your specialists one by one. At that first visit, your new PCP will probably review your diagnoses, any surgeries that you've had, and the medications that you take. It's helpful to bring a list of your team members, such as specialists, therapists, DME companies, and your supports coordinator. If you have guardianship or power of attorney paperwork, that's great. And if you need guardianship, we can fill out that paperwork or even testify once we've gotten to know you. Medical clinics will pretty much always talk to caregivers, but insurance and DME companies might require proof that the young person is unable to represent themselves. We can also get you a patient representative form so that you can set up a patient portal account on their behalf. So the adult version of My CHP is My UPMC on the UPMC side and My Chart on the AHN side. And at this time, adult providers can sometimes see some pediatric notes, but not all of them typically. And this brings me to my last topic, which is one that causes a lot of angst, and that's inpatient care. Children's Hospital of Pittsburgh will admit you or your young person until the age of 26, but no later than then, they do expect you to move into the adult system. This is to let younger patients use those beds, and because the older you get, the more likely you are to have adult problems. And while the buildings may not be as pretty to look at as this one, the people in them are just as caring, and the tools and equipment are the right size for adult bodies. You can, of course, go to the closest hospital, and I have, for instance, heard wonderful things about St. Clair Hospital. At UPMC, burn care is centered at Mercy, and Shadyside Hospital is the place to go for cancer care. If you have many UPMC specialists, you might want to go to the Presbyterian emergency room. Surgical patients are usually admitted to Presby, while medical patients are usually admitted across the bridge at Montefiore. Just like at Children's, your care will typically be in the hands of a hospitalist, a doctor who specializes in patients who are in the hospital, or maybe a teaching team consisting of a supervising attending physician, overseeing residents who are already practicing doctors with MD or DO degrees, and medical students who are nearing graduation. With a few exceptions, your PCP or specialist will not be the person in charge of your care in the hospital, but they might stop by for a visit and/or talk to the team. And then after any hospitalization or serious emergency room visit, please call your PCP or specialist to make an appointment to review changes to your care. Hospitalization for any reason is already stressful, and changing from children's to an adult hospital may be the last great leap in medical transition. And here are a couple of things that I'd like you to know. The first is that if you take care of a young person with increased communication needs, they have the right under the Americans with Disabilities Act to have a caregiver remain with them 24 hours a day, 7 days a week. I know that at the beginning of the COVID-19 pandemic, the rules were really strict about accompanying adults, but those have relaxed. Masking is also optional, although you do have the right to request that caregivers are masked when they are in your room if you're worried about infection. Many shared rooms are being renovated into single rooms to create more room and privacy so that a caregiver could spend the night. And if you can't be physically present, go ahead and leave your phone number on the whiteboard in the room so the team can call you during morning rounds or if there are updates later in the day. At UPMC, the Disability Resource Center runs a service called Let UPMC Help You, or LUHU. You can contact them before a clinic visit or during an admission if you have any questions about accessible parking, bathrooms, an iPad with communication apps, or what to do with a service animal. And that's it. Transitioning from the comfort of pediatrics to the strange land of adult medicine can be anxiety-provoking. Please know that there are a lot of people who want to help you succeed and are here to point you in the right direction. I like to tell my patients, I know you just spent 20 or 25 years with your previous provider, and I hope to care for you for at least as long.
Thank you. Great talks, everyone. We'll save the questions till the end, but before that, the last speaker of the session is a very special guest whom I know very personally because I take care of him. He is James Backenheimer. He has a history of congenital heart disease. Now he's a thriving middle-aged old man, and he's here with his daughter, and we're very honored to have you here, James, and come on up and share us your experience. Thank you.
Good morning, everybody. As Dr. Hospital said, my name is James Bockenheimer. I was born in Long Island, New York in 1981. I'm 41 years old. Next August, I'm going to be 42. My daughter, Brooklyn, she's over there in a little denim jacket. I had my Fontan revision when her mother was pregnant with her, and I had that here. Prior to that revision, I was still in pediatric care, which I had been for all my life. The youth was the easy part because you did have that care team with you. You had your doctors and you had your mom. My mom was always with me. She took amazing care of me. And as a couple of doctors were up here talking about, the mother was tearing up when you're about to turn their child to transition care and have them care for themselves. I could totally understand that. And it's a difficult process for the family, and working on it together with your medical team, with your family, with your patient must make it a lot easier. Unfortunately, I didn't have that. Growing up, we were always just pediatric patients. As I got older, teens, they were tough. I had a lot of anxiety and a lot of depression about what I had gone through and where I was going to go, because quite frankly, I never really knew anybody that had HLHS, that had a Fontan, that definitely was not any that were an adult that I knew. So it was a little scary moving forward as a young man. And that led me to make not a lot of great choices. One of them was falling out of care. And when I fell out of care, my health just dwindled. My family eventually left Florida. My sister moved to New Kensington, and it was time for me to go somewhere. My doctor in Florida, Richard Martinez, told me about this real good surgeon that used to work with him named Dr. Morell. So I came here because that's where he was. I met Dr. Bierman, and he started to transition me over to Presby. We'd work with Dr. McNamara over there. Dr. Bierman would talk, and they got to the point where I said, James, we're going to transition you adult care. We're going to do this Fontan revision. And I started to become a little bit more of my own advocate, a professional patient, which I like to say that term, professional patient. I think it's very important that you know exactly what is going on with you and that you're in the room with your parents when you're learning all this. I had just thought that I had a half a heart. It was half a heart. That's what it was when I was a child. When I started to transition, I learned what HLHS was. I learned I had transposition of the great arteries. I didn't know anything about that. The importance of today's generation getting that, I think, is a difference between falling as a young person and catching yourself and being able to be a successful working individual, a productive individual with a happy, full life. And it really happened here for me. I was on disability. I moved to Pittsburgh just because I thought I was disabled. I had half a heart. Why not, right? So I began to learn a little bit more about myself, that maybe a lot of the things I was going through were mental and anxiety driven, which they were. I believe the heart stuff was not as bad as I had made out to be in my mind. And that's another thing I like to see, what you guys were going over on the slides, which I'm not a slide guy, sorry. But when I see the mental health care and that is so huge, having a mental health psychologist, therapist, whatever it is in your corner that you could talk to and you could tell your emotions to. Because sometimes that's very hard to do with your parent or even with your cardiologist. So I love seeing what you guys are doing here. It's hugely important. Now, being here and becoming my own advocate, learning about the importance of a healthy diet, learning about the importance of exercise. When I was little, they would tell me, no, don't push it, Jimmy. You know your limits. I feel like now, knowing what this can actually do, that I can really know my limits, know what I could really do, that I could get up in the morning and I do it. I could walk 3.5 miles just fine. I could do a 5K a day. I've done it. I attribute that to being able to go to work and work 50 hours a week, which I just did this week. I sell cars. I'm on my legs a lot. I'm always moving. I'm always doing something. And I outwork a lot of people that have a left ventricle, a right ventricle, and all the atriums and everything they should have. So my prognosis growing up was not as bad as I thought it was. It's quite hopeful. I guess there's some patients over here with it. That's awesome to see too. Other people hit adulthood. That's great. I love it. I honestly really didn't know what to say when I came up here, other than you need to take care of yourself and you need to be your own advocate. You need to sit down with the doctors. You need to be part of the team, and you need to know what you can control and worry about that. Worry about what you can do, not the outside influences, because you could do so much. You have so much to put into your body that is healthy. Exercise, high fiber, low fat, proteins. I know a lot of us have liver problems. I do. I have PLE. So eating healthy is very detrimental to my health. I have to do it, or I'm going to be one of those patients that kicked out of here and I got to go lay in Presby and the food isn't as good. So I don't want to do that. I want to keep moving and I want to keep walking, and I want to eventually see something up there for elderly care and transitioning to that, because I think that's a huge possibility. I'm pretty confident that I could retire Dr. Hoskipel. So I plan to grow an old man together. And I don't think I could do that without programs like this, without doctors like you people here, and without this amazing UPMC health system. And I hope I'm speaking in the mic, sorry. But that's really what I have to say is be your own advocate, be a professional patient, and worry about what you can control. Work together or a team. We all want to be old people, and we're going to get there. And thank you. I know it wasn't 15 minutes, but.
Okay. Thanks, James. That's a great, heartwarming story, and thanks for sharing with us. Like the term professional patient, that I'm going to start using that. You know, I've seen it before, but yeah, that's a great term. With that, we'll open up for questions. And
as we open up with questions and we're looking at the chat, I can start one for each answer real quick. One of the things there we go. We'll restart. Okay. One of the things as we're looking in the chat, and if you're online, please add some questions. If you're in the audience and you have a question, go ahead and raise your hand and we can bring a microphone to you. But one question I'll start with as we're waiting for those is, you know, transition's really challenging. There's also many different perspectives, different stakeholders in the process. And I wonder if you guys could each comment, and maybe we'll start with Dr. Ehrenberger since she's furthest down and work down the line, of if you were to say what a good transition looks like, what does a good transition look like from each of your different perspectives? If you were to define a good transition, what would that look like from your specific perspective as an adult provider, as a pediatric provider, and then of course, most importantly, as a patient?
I think from my perspective as an adult PCP, a good transition really involves good communication. Because we take very seriously the responsibility that we have for our patients. And so I dislike surprises. I really am looking for the pediatric PCP or specialist to let me know what the young person's major issues are so that I know what I'm walking into the room with. Sometimes I have to do my research before I meet them because we do take care of individuals with every kind of condition. And so it's just like nice to know beforehand so that we can meet together and make some goals and reach them.
I definitely agree with communication. What I would add to that is engagement for all the stakeholders. So when we look at the team, I need to know that all my team understands that it's time to be thinking about transition with this 13-year-old and move them along, because we have to have a solid approach, a unified approach when we talk about transition with our patients. We have to have engagement of the family that this will work. And sometimes that first, with the introduction, as I mentioned in my presentation, is a little bit rocky, but the parent caregiver has to accept that that's part of their child growing up. And then the teen has to engage. And I think that's probably what makes, when I think of my patients who've done this very successfully, and I have some patients now that were enrolled when they were about 14 and they're hitting that 18-year-old period now with being in our program, and they really engaged nicely, and it makes each of these sessions flow so beautifully. And then certainly engagement of the adult provider and their team, so that it's not like, oh, well, they're sending us our problems, which actually we don't hear about anymore. That used to be the biggest problem with the adult side, like you just want to get rid of them. But I think the adult side has done a great job in all the hospitals that I've been dealing with about understanding that they need to accept this. There needs to be a willingness. So I need those adult people to be engaged where the young adult is at that time, which might not be perfect, but how can we do that overlap? So I'd add engagement to communication.
We have to, as a patient, know a little bit of what is wrong with us, actively listen to our physicians. I like to look up everything about my health. Yeah, I like to know what the words are, so I'm sitting there and the doctors are talking, okay, I know what that means, I could follow along here. Like I said earlier, be a professional about what is wrong with you, be part of the team, listen, and be able to relay to your physicians what you're feeling, what's going on in here, what's going on in here, and what you feel you need to get you to hear. All relationships need communication, whether it's your marriage, your doctors, or coworkers. Listen.
While we wait for questions from the audience, I have a question to the panel. Like, it's about resources for the transition program. It's quite resource intensive, but in this current reimbursement environment, it is not actually a reimbursable service. So how do we reconcile the difference at our level and also at the policy level?
To a certain extent, we are victims of our own success. I think what we're seeing now is a generation of young people who have survived the NICU, they've survived the PICU, and now they're coming up into adult medicine. And so on the one hand, I think as a society, we have this idea that all babies are born and they grow up and they become independent adults as a society. And this isn't true, because there are some people who are going to need more help than others. And rather than putting the onus on the growing young adult to be able to coordinate all of their care, I think our various medical societies are really going to have to work together to make this a policy priority, so that people aren't left in the lurch and in the gaps, because this is a matter of life and death.
Yeah, I agree with that, and I was going to say the same thing. I think that's where our organizations for our specific conditions come into effect. And I think that when we do position papers, white papers, that when we are talking about our outcomes, like we know there's plenty of literature right now, particularly in kidney literature, where that gap between pediatric and adult care has an increase of up to 20% mortality in that group, that they don't make their first appointment after transfer, or their first time they see a physician is in the ER, not because they broke their leg playing softball, but because they're jaundiced and their friend said, you should go check that. So I think our organizations can set up standards. And then, for instance, like CMS in transplant, the Center for Medicaid Services mandates that all of our patients have a social worker assessment and a psychology assessment pre-transplant and post-transplant. So similarly, I know that the United Network for Organ Sharing is working on a transition policy. So I think when they see that this is important for good outcomes, then this will be mandated too. Just like I think we all owe our transition programs to the pulmonology people, because years ago, I think somebody correct me, I'm not sure the exact organization, but I want to say the American Lung Association said that they wouldn't accredit hospitals in providing care for cystic fibrosis patients until they had a documented transition program. And that all started at the University of Wisconsin. And in our group at AST, we worked with the University of Wisconsin people from their cystic fibrosis template to develop what we did. So I think when it's mandated, that'll help us get the resources that we really need to make this a comprehensive program.
I can ask another question for each of our panelists real quick. Bev, in your talk, one of the things you said was it's important for people just to at least do something. And I would say, doing something is picking about that one next step you're going to do. I always think of transition being about a journey, and a journey is thinking about where we're going for a destination. We have to do step after step. I love these different perspectives of communication being really important, engagement, and then the professional patient. So really about being independent or interdependent. If from each of your perspectives, what would be just one step that we could take to help think about making transition better? If you were just to say there's just one thing from your perspective as an adult, pediatric, or as a patient that would help with this transition process, what's one step to take?
One step from the patient is I wish I would have had a roadmap of where I actually wanted to be in life. You can go to college. You still got to go to your doctor appointments, but you could go to college. You don't have to get doctor's notes for not doing certain things. You should plan, I'm going to do this. I want to, I can. And have a roadmap like that medically as well. To get here, I have to see my doctors. I have to do my blood work. I have to follow up and know what's going on. Then I'll go to class and then I'll reach my goals.
I would agree with that. I think it's the communication that I would start with, and that's kind of how our program started, that we would just discuss it, like, what do you think you're going to do, and talk about that. I like your idea of a roadmap, and there are some tools out there for that with the gut transition, but to just talk about it and think about the plan, because a lot of my young adults aren't thinking past a certain point. So how do you push them to think about it? So I would just, again, talk about it.
It's not only the young adults who aren't thinking about it, because I will not infrequently receive somebody in primary care. They may be 21 because their pediatrician will no longer see them, and their specialists have not talked to them about transition yet. So if the specialist isn't going to bring it up, then the caregiver or the patient needs to just ask, how long are you going to see me? When should I think about going to an adult provider? Do you know somebody on the adult side that maybe I could see?
Thanks. Oh.
Thanks. So I am a CF doc, so it was the Cystic Fibrosis Foundation who really pushed this. And they said, you need an accredited adult center or we're not going to accredit you, period, if not 90% of your patients by age 21 aren't transitioned appropriately. And I think that's wonderful, and I think that that mandate really did push health systems and institutions to do that work in getting things set up and resourced. And the CF Foundation further doubled down, and they give resources to our programs where we have social workers and a multidisciplinary team that are funded externally from our hospital by the foundation. I think my question is, for disease states or chronic conditions that don't have an advocacy association that is that well funded and that forward thinking, how do we as an institution really move the bar forward without waiting for these disease mandates? And I think that my question is, kind of piggybacking onto yours, Andy, what resources in the ideal world would you like to do this work the best that our patients and families need?
Wow. I agree with you. I think that if you do have an organization, it certainly helps, and at least you're starting somewhere. So for those that don't, is there some place you could partner with, or is that where our hospital becomes very important? So we need to have, and I know we're working on that in our task force, where we have a uniform policy for the hospital. And so how can we launch that within our hospital so that the other groups are also accounted for? And we're also working with that with the transition services that we're starting with, the medical department. I forget which department's starting that. For the consults for transition. Adolescent medicine is starting. So I think that when they fall between the cracks, then we have to have the hospital there to be guiding that.
Yeah, No, you're exactly right, Bev, because it's in the interest of, in this case, Children's Hospital of Pittsburgh, that their young adult patients move on to adult care to make space in those beds for the younger patients, as well as to ensure that they're getting the care for their stage in life, for those adult problems and those adult bodies.
And so this may just be a teen that happens to be in the hospital for whatever reason. It might not be a serious chronic condition where they would fall into the cracks, so to speak, but it's still important that you contact that teen when they're in the hospital. So this consult service will be really important for them, because everybody needs help. Like, for a young woman, when do you first start going to see a gynecologist? How do I get a PCP? I mean, I think that's one of the trickiest tasks. I think Kristen brought that up. One of the trickiest tasks for my patients is finding a PCP. We have the specialist doctor, but I need good internal medicine people to follow my patient comprehensively.
And would I be able to just make one quick comment also based on Tracy's question there of how do we do, I would say culture shift is really what we're looking at. And I think there's two really important things. I think Bev talked about this in her talk, policy statements, right? As an institution, policy statements sound very boring, but it means that an institution has created a stance that they are going to invest in a specific area. And for UPMC or a hospital system to have a true policy statement around a transition, it doubles down and says, we are investing in that. So that's an important thing. The second thing is that I think that there are too many silos, and we have to think about how do we break down the silo of the hospital system and the community, right? Often we think about these in different areas, and what happens is we start kind of coming from an angle of how do we do work on a community rather than with the community, right? And so we need to figure out how can we make this a bigger conversation where we're all working together, because the reality is, I'll just give a shout out to the Down syndrome community. That's where I work. The only reason why I have a transition clinic is because the Down Syndrome Association of Pittsburgh, which is a family-based nonprofit, funds our clinic so that I can spend up to 2 hours with the family. That's the amount of time you need to really do transition well. You need time, you need those resources. And it's really that partnership of the hospital and the community that makes that work. And we have to figure out how to do that better so that we can actually make a better system for everybody. Because the reality is there are going to be people in groups that they don't fit a specific area. They don't fit a specific clinic, but if we build this together as a community, then we can actually help everybody. So I think it's really important that our hospital kind of creates a policy that they double down and say they're investing, and then we need to break down silos. We need to be able to work in combination with our communities to be successful.
Yeah, thanks. I think we have time for one last question. One of the questions posted was, when does the process of transition start? And at what age? And I'll answer with my perspective before I ask the panelists. This can start even before birth. We are making a diagnosis of, for example, congenital heart disease in utero. So, and the counseling that this is a lifelong condition and it is treatable, but you do need to transition into adulthood. So that's kind of like a philosophical answer that it can start at any point, but I'll open up to you guys to see if that's the right answer.
I think adolescence, 11, 12 years old, when you're really becoming your own person, and once that little bit of puberty starts to set in and you're becoming your own person, that would be an absolute great time to start transitioning a patient to taking over their own care. I mean, they're going to have to start doing their own homework. They're no longer in elementary school. It really is a great chance to do it all in that step. You can do it little by little when you're 11, 12. Then by the time you graduate high school, you should be a fully functional adult, ready to go on your own. At 7 years is very important, I think.
Our program, as I said in my talk, officially starts at 13 when we give them the policy and we start them, but we talk about it before that. So when we're evaluating a new, a 6-month-old with biliary atresia for liver transplant, or a year-old patient with gastroschisis for intestine transplant, that is part of our evaluation process. So we do a full educational session with a PowerPoint program, and they see a slide about transition and what that's about. And in some cases, it's almost encouraged, it's a positive thing, because some of these parents are worried that their child won't reach puberty, won't be 13 to transition. So that's often, it's interesting when I do that with some families, that's when I see the tears, because they see hope that after transplant, their child will have a longer term survival. And I will have to worry about those teenage things. I mean, they kind of want to, it's a good thing. So officially, but we start earlier. And then it's also, I didn't do this in my talk, I mean, there's so many things to talk about with this, but for our patients that are in the hospital, and for those of you out there that are in the hospital, it's important to still be that advocate when you are there and to know what's going on with your care. And for the nurses, and this is another area I need to do a little more work on, when they have a 15-year-old patient that they're going in and asking them what are these meds that I'm giving you today? When do you take them? What do you worry about with the medications? So that from all the systems around, even when they're like 11, 12, 13, that we are still addressing transition with them.
Yep. Thank you very much. With that, we'll wrap up this session. Those are fantastic talks. Thank you, everyone. And just a couple of announcements. We're going to be taking about a 10-minute break and reconvening at around 10:30 or at 10:30. And those will be breakout sessions. For the online audience, you should have received links, and it's also posted in the chat. If you want to do the first session, sexuality, contraception, and reproduction, you stay on the main Zoom link and in this room, and the other two will be in the other links posted, or you should have received those through your email as well. Thank you, and we'll reconvene at 10:30.
Yeah, nice job. So are you still seeing Unico in the congenital?
Every 6 months.
See, I would really like to do a congenital.
It's nice to be in
Yeah,
Pete's.
and I'd like to hear.
Oh, yeah.
Thanks.
All right, I'm going to get started with the beginning of this breakout session. So just to introduce myself, I'm Kirsten Rose Felker. I'm one of the pediatric cardiologists here, and I specialize in heart failure and transplant cardiology and have worked on transitioning a lot of our patients to the adult side. I have the pleasure of talking about this topic, safe contraception and chronic disease conditions, and have no disclosures except that this topic is definitely out of my wheelhouse, and I think learning more about this and being present to help answer questions or provide some information to you has really been helpful for me as well. So the role of the pediatric provider in contraception, I think these are sobering statistics. As we know, many of our adolescents report special healthcare needs, and sexuality and associated healthcare needs may not be addressed in this population. And while about half of students reported ever having sex in a survey in 2011, many without adequate counseling from the medical field, data supports similar levels of sexual behavior in this complex medical needs group. The role of our pediatric group is to just help guide adolescents and young adults through this by obtaining a sexual health history, screening for pregnancy and sexually transmitted infections, and counseling. If indicated, our role is also to provide access to contraceptives. And this statistic I found very hopeful. Adolescent pregnancy and unplanned pregnancies has decreased significantly from the 1990s to early 2000s. A large portion of this is attributable to increased contraception use in this population. There's many reasons that contraception can be provided to adolescents and young adults, and I think this is a really easy way to start this conversation because it might be a little bit uncomfortable for some of our patients. We have to remember that dysfunctional uterine bleeding, acne, dysmenorrhea, and then menstrual suppression of menstruation may be all indications to provide these medications and forms of contraception. So how do you bring this up? I think for me, this can be one of the hardest things.
we recommend using motivational interviewing, which is really asking our adolescents and young adults to ask us what they have, what they're going through or what their thoughts are, listening and avoiding judgment. We can focus on their goals, values, and relationships. For example, if college completion is a goal or ongoing participation in sports is a goal, we can really kind of use that to frame how would an early or unplanned pregnancy or having a sexually transmitted infection impact these goals. And then confidentiality is a huge barrier. A lot of adolescents and young adults may be unaware that these conversations are protected as confidential information. And it actually may be one of the reasons that they forego healthcare altogether or choose to not talk to us about contraception. So this is how I feel when we get to the point where an adolescent or young adult needs contraception is, where do we start? Especially if you have somebody that's on taking other medications or has other medical issues, where do we go from here? So I think if you break it down by why are you using contraception, that may be able to help a little bit. And then I'm going to highlight at the bottom, there's a CDC guide to contraceptive needs in people with medical conditions, which I think is incredibly helpful. And I included the link, which I think should be available to you on my slides. But are we using this for pregnancy prevention? And do you need to consider if your patient is interested in having return to fertility in a short period of time? Is it STI prevention alone? Are there specific medical concerns? So I think one place to start is just really understanding how effective different methods of contraception are in preventing pregnancy. You'll see on the left-hand side is typical use and on the right-hand side is perfect use. The difference between these, typical use is, this data is obtained by national surveys with users that have varying levels of adherence or taking the medications or using these methods in a typical situation, versus perfect use is these are data obtained from clinical trials where there's a lot of supervision and surveillance to make sure that that methods are being used consistently. So we can see here, I think if you use a single method of contraception alone, for example, condoms, the rate of unintended pregnancy in the first year of use is quite high. And so I think we really need to consider, since many of these are not available without a prescription in the state of Pennsylvania and our surrounding states, that as healthcare providers, we really need to help our patients do better. So I'm going to give a quick overview. And again, I am no means an expert in this, but this is an overview of some common methods of contraception. So starting with progestin implants, these are, it's an implant that's inserted in the non-dominant upper arm. And this is a single progesterone-eluting rod. And these are highly effective. They can remain in place for several years. This is something that can be done in a routine clinic visit. The insertion of this typically takes a minute, and removal can be a little bit longer, but really in the realm of minutes. These are safe in women with estrogen contraindications. So these may be women that have blood clots or other medical conditions. They're good for those who have trouble adhering to a regular schedule. And I think all of us can relate to having trouble adhering to doing something every single day at the same time. These can often reduce uterine bleeding in periods, which may be a pro for our young adults. The cons is that the most common reason for discontinuing these in young adults is that you may have spotting or irregular menstrual bleeding. Experience in the first 3 months of using these is best predictive of the future use of how that side effect is going to be. And so it's definitely worth counseling individuals who are interested in this form of contraception that this may be an issue. And then some people report emotional lability, acne, headaches, and weight gain. It's also important to remember that we counsel our patients that abnormal uterine bleeding can also be a sign or symptom of a sexually transmitted infection. And so that's something they should bring to our attention. Intrauterine contraception, or IUDs, this is a long-acting reversible contraception. There are 3 different forms that are FDA approved in the United States, and these prevent fertilization by inhibiting sperm motility and thickening cervical mucus. There were prior concerns about the use of IUDs in young people who have not had children, having potential issues with future fertility. This has been largely discredited and thought that some of the association in some of those earlier studies may have actually been more related to sexually transmitted infections. So that is no longer a concern. In terms of pros, these are very safe and effective. The failure rate is less than 1%. And worldwide, this is a major form of contraception that is gaining popularity in the US. People tend to be highly satisfied with these, although we have less data on our younger patients and adolescents. These can lead to improvement in dysmenorrhea and even amenorrhea. These can be helpful for long-term menstrual suppression for that reason. Patients will need to be screened for sexually transmitted infection at the time of insert of one of these. There's a small increase in pelvic infections if there's a current sexually transmitted infection, but the risk of that after 20 days of insertion is not increased due to the IUD. There are reported higher rates of expulsion and discomfort on implant in women who have not had a child. And then we're very lucky here at Children's that we have pediatric providers who are trained in placement of these, but this may be a barrier for some of our providers in the community, that this may be an access issue, as you may have to find a provider that's willing to insert this. Contraindications for an IUD are a current or recent pregnancy or pelvic inflammatory disease. As providers, we are able to treat sexually transmitted infections and deal with this on a subsequent visit. And so this is something to really talk to providers about. These are the three that are approved in the United States. The Paragard or copper IUD is the one on the left side. This has the longest approved use. And then there are two progesterone, releasing IUDs, the Mirena and the Skyla, which are approved for 5 years and then may be effective up to 7 years, and then approved for 3 years at a lower dose of progesterone. Depo-Provera or progestin injections. This is a long-acting progestin that's given as a single injection every 13 weeks and can extend up to 15 weeks. This can be delivered intramuscularly in a clinician visit, and there is more investigation that's ongoing about self-administration with subcutaneous injections. These can be used any day of the menstrual cycle, even if pregnancy can't be ruled out, and often in that case, there's a recommendation for a pregnancy test a couple weeks afterwards. These are also good for those of us who have trouble adhering to regular schedules, and they can improve dysmenorrhea and protect against iron deficiency by decreasing uterine bleeding. These are also safe for people with most chronic illnesses and can have additional benefits in medically complex individuals, like raising seizure threshold or decreasing sickle cell crises. Cons of these: there's a possibility that these could increase the risk of DVT, but the benefit outweighs the risk in patients that have a history of clots. Again, with a lot of these hormonal contraception, there may be menstrual cycle irregularities that will improve with time. And then I think it's the need for repeated injections and ongoing follow-up with the provider that can be a reason to not use this for a long time in some individuals. There is, I think, bone mineral density is probably the biggest thing to cite here. This is something that should be considered on our patients that are on chronic steroids or have other risk factors for bone disease. Although there's 3 prospective studies that have been done in adolescents showing an early return to bone health after cessation of these. And there's no recommendation to routinely follow bone health because of that. Combined oral contraceptives, this is the most common form of contraception in the United States. For adolescents. These all contain, these are combined estrogen and progestin supplements, and you can use higher dose or these low dose forms that may be a good way to start our adolescents. These are reliable and effective, but require regular use at the same time every day for the best efficacy. And these are available by prescription in the United States. So it's important to counsel our minors that it's possible that if this is being prescribed through an insurance plan, this could result in notification of the family. And so this is an important discussion for our adolescents to have with their families and for us as healthcare providers. We always recommend a backup method with this because there is no protection against sexually transmitted infections, but certainly for contraceptive purposes in the days surrounding starting these. And then adverse effects, you can have transient or irregular bleeding, headaches, nauseas, and then blood clots are one of the reasons that people are most afraid to use these. Contraindications are severe and uncontrolled hypertension, hepatic dysfunction, complicated valvular heart disease, migraines, complicated diabetes, complicated solid organ transplant, and some certain bleeding and clotting disorders. Although it's worth noting that the risk of clotting in pregnancy outweighs the risk with all of the combined oral contraceptive pills, and this should strongly be considered. In terms of prescribing these pills, there's a whole lot out there. Some of the common things that you may hear of, there's monophasic versus phasic, which means that the dose of the hormones may vary throughout the month. Typically, these are prescribed in a 28-pill pack with some placebo pills that you may see here. And these can reduce acne, decrease menstrual cramping, decrease blood loss. And some of the newer pills may be packaged without any placebo pills for extended cycles. And those can really be helpful in those with heavy bleeding issues or conditions that are exacerbated by cyclical changes. There are medications that our patient population may use that can decrease the efficacy of these, and this is important in counseling our adolescents and young adults. And then the contraceptive vaginal ring or NuvaRing ring. This is a estradiol-related ring that's inserted into the vagina and protects against pregnancy for a month. This is round and flexible. It's recommended by the AAP that we use a model or a diagram when we're using this form with adolescents to just kind of demonstrate proper use of this. It's a simple regimen. It can be used the same day start as the clinic visit, and it's considered to be bone neutral with unclear data about clotting risk. Adverse effects of anything with all contraceptives really can be breast tenderness, headache, breakthrough bleeding, and nausea. And then the transdermal contraceptive patch or ortho-evra. This is a hormone-eluting patch that's placed on the upper abdomen, torso, outer arm, or buttocks, and one patch is placed for 3 weeks in a row with a 1-week off period for breakthrough bleeding, although continuous use can be used. The estrogen exposure is higher than in some combined oral contraceptive pills, and there's an increased risk of thromboembolus, not significantly higher than combined oral contraceptive pills, but also something to strongly consider. And these may be associated with a high risk of discontinuation. Side effect profiles are very similar to combined oral contraceptives, although there may be some local skin-related effects too. And then the progestin-only mini pill. This works by thickening cervical mucus, and this is recommended for ongoing use to take very consistently. It can be used before a sexual encounter takes place as well. These are generally considered less effective than combined OCPs. Irregular bleeding is a common adverse effect, and these are generally not recommended as a first choice in healthy adolescents. Male condoms are something that we should be providing and counseling patients to use every single time, despite prescription contraceptives. These are the best way to prevent sexually transmitted infections. They can be, they're available in both latex and polyurethane. Natural condoms should be discouraged because of their poor ability to protect against sexually transmitted infections. And these are easily available and don't require a prescription, so it should be something readily available. And then I just want to spend a minute talking about emergency contraception. There are a few different forms available of emergency contraception. The levonorgestrel or progesterone only form is the one that you see on the right, the Plan B 1-step. It's important to note that this may lose efficacy in women that are over 165 pounds. And so this is worth counseling about that. It is available for women over 17 by the FDA without a prescription, although this has been challenged in some states recently. Also, there are additional forms of emergency contraception that are available, and these are most effective that are used within 5 days after unprotected sex. The sooner the better. The reason I want to talk about this is something that an advanced prescription should be considered in people with chronic health conditions, because data supports that this does not increase their risk-taking behavior and may really help in a situation that was unplanned. And there are no medical contraindications. When looking at just some kind of quick, big medical conditions and what are some considerations, in our population with obesity, we talked about how emergency contraception may be less effective. In addition, the transdermal patch may be less effective as well. We need to remember that metformin and bariatric surgery can increase ovulation and increase the risk of fertility or increase fertility, and that we really need to think about using it in these situations. In patients with HIV, antiretroviral agents may have interaction, and then condom use should be used regularly for prevention of transmission. For those with solid organ transplants, typically we would recommend a period of organ stability, largely because there may be drug interactions, especially with combined oral contraceptive pills, although there's no contraindication to using them earlier in that period. It's recommended to avoid estrogen in patients with coronary artery disease. And this is really a population that we should consider discussing emergency contraception. And then in the oncology world, we've talked about extended use of some contraceptive pills or other forms for heavy menstrual bleeding, bleeding disorders, or with chemotherapy. And then I'm going to end. There's a really great, in this article published by the American Academy of Pediatrics in 2014, there's this really great resource within there, in addition to that CDC document, going through with a lot of resources that may be available to print in your clinic or have when you're looking to prescribe these forms. All right. Thank you. I'd be happy to take questions as part of the panel.
Hi, everyone. I'm Malamo Contouris. I'm an adult cardiologist, primarily based at McGee Women's Hospital, and I also do a little bit of time at Presbyterian Hospital. I'm going to be talking to you today about high-risk pregnancies and specifically heart disease in pregnancy. So you'll see my talk will focus specifically on heart disease, but I think you'll find it applicable if you have, other diseases of other organs. I think the sort of framework of a multidisciplinary team caring for you during pregnancy will be applicable. So I'm going to start first by talking about why we care about heart disease in pregnancy. And kind of the focus of the talk will be about the multidisciplinary team that we use at McGee and is used at other institutions, where we have we call a cardio obstetrics team. So basically not just cardiologist, a subspecialist caring for individuals during pregnancy, but also collaboration with our maternal fetal medicine providers and other subspecialists as well. We'll talk about what medical conditions we treat, how we assess cardiovascular risk in pregnancy, and then a little bit about timing. So when is the best time to see your subspecialist to talk about pregnancy, and then throughout sort of the pregnancy and postpartum timeline. I'm going to start by setting the stage, and this slide is not meant to scare anybody, but I do want to highlight that we have a problem with maternal mortality and morbidity in this country. In the United States, we see increasing rates of maternal mortality over time in the past about 20 years. That is different than other developed countries. We see actually decreasing rate in most other developed countries, but the United States, we're doing a particularly poor job of caring for women with cardiovascular conditions and other conditions with rising maternal mortality rates over time. This is contemporary data, so it spans from 2018 to 2021. You'll recall that covers a time period of COVID-19. And so some of these increased rates probably are related to COVID. And you can see on the y-axis, I am showing maternal mortality rates, and it's kind of divided by race and ethnicity. This has been all over the news, so I don't think it will be surprising to anyone that we see more than double risk of death for Black women when we compare to other races and ethnicities. So particularly for Black individuals, we need to be doing better. And then when we break down by why individuals are dying in relation to pregnancy, there's a lot of this is from cardiovascular causes. And I think that's why it's particularly importance that we as cardiologists are paying attention to this. So I've highlighted on the left-hand side of the screen the more common kind of causes of maternal mortality being hypertensive disorders of pregnancy, cardiomyopathy, and other cardiovascular conditions. Black individuals in particular are affected by these cardiovascular conditions and are more likely to die from those. Why do we think we're seeing, maternal mortality and morbidity related to pregnancy? Well, essentially, pregnancy is a 9-month stress test. If you can imagine, individuals now need to supply blood not just to themselves, but also to the fetus. And in order to accomplish that, we increase cardiac output. So literally with each squeeze, the heart is pumping more blood. That's an increase in stroke volume. And we also see an increase in heart rate. These are the kind of hemodynamic changes that we see also with exercise. And so it's sort of like a 9-month stress test, if you will. The heart actually goes through changes during pregnancy to increase that stroke volume and cardiac output. The heart muscle thickens, the heart muscle dilates, the left ventricle dilates, and these are normal changes in pregnancy. But for people who have already underlying cardiovascular conditions, some of these adaptations that the body needs to make are much harder and sometimes result in adverse effects and sort of inability to tolerate the pregnancy state. On the right-hand side of the screen, I'm just showing the percent change from pre-pregnancy in each of these measures of cardiac output, stroke volume, and heart rate. And if you look at the sort of slopes of the lines, the biggest change are happening in that kind of 8 to 20 weeks of pregnancy, really majority happening in the early second trimester. We see the biggest changes. And so if we're going to see symptoms develop, oftentimes we'll see them start in kind of the second trimester or late second trimester of pregnancy. I'm going to talk a little bit about our multidisciplinary team, but before we do, I wanted to just give a very brief overview of some of the conditions that we treat. This is not an exhaustive list, and I've divided by congenital heart conditions, which are ones that people might be born with, and then acquired heart conditions that we think develop throughout the lifespan. But I'm listing some of the common congenital conditions that we see, and then on the acquired heart disease side, we see people with heart failure, cardiomyopathy, coronary artery disease, higher risk conditions like pulmonary hypertension, and on the congenital side, things like systemic right ventricle or aortopathies, really require a comprehensive kind of risk assessment prior to pregnancy and very, very close management during pregnancy if pregnancy is not contraindicated. So here are some key components of our multidisciplinary team. Of course, we have, sort of the cardiologists that specialize in care for women during pregnancy. These are what we call sort of cardio-obstetrics cardiologists. Our adult congenital heart disease specialists also care for individuals during pregnancy. We partner very, very closely with maternal fetal medicine specialists. So we actually, have direct lines of communications happening all the time between cardiology and maternal fetal medicine, whether that be via text, via email, via messaging in our electronic medical record, sharing notes. And then when we think about delivery planning, we need to involve our anesthesiology specialist as well to help us figure out, adequate pain management, timing of delivery, mode of delivery. And then I have on here also our nurses and our advanced practice providers, which are pretty key in helping us deliver the best care that we can. And all of these team members are present. Once a month, we have a multidisciplinary virtual meeting where we talk about each of our highest risk patients, and we kind of go through in detail the risk assessment, timing, management during pregnancy, medications, cardiac testing, and then timing and mode of delivery. So it's not just one individual making these decisions. We decide as a group what is safest for each of our patients. This is our cardio-obstetrics team, some key players, and you'll recognize, I think, some of these faces from today. From the adult general cardiology side, we have myself, Dr. Kozo, and Dr. Berlacher. We all see patients at McGee in our Women's Heart Center. On the adult congenital side, we have Drs. Saraf, Wolf, and Hoskapel. Dr. Ricky Hansra has a unique kind of training background. He's a critical care cardiologist, so he sees patients in the ICU, but he also has some training in cardio-obstetrics. So for most sick patients during pregnancy, he provides expert guidance for us. And then on the inpatient side, we wouldn't survive with two of our nurse practitioners, Kim Bollinger and Kristen Weber. They help us see all of our inpatient consults. And they actually keep a running document where we have each of our patients, their conditions, their recent testing, so that if we ever need to, if we ever have a question on some of the discussions that have happened in the past about a particular patient, they have that all documented and saved within our UPMC system. So what do we discuss when we have our multidisciplinary team meetings? I mentioned this. The first is sort of cardiovascular risk assessment that may be associated with pregnancy. And on the next slide, I'm going to talk through how we assess cardiovascular risk. Follow-up intervals are really important. So talking about when we need to see you back during your pregnancy, and that will span from pre-pregnancy all the way postpartum. After delivery, we still want to be seeing patients and making sure they're not developing new issues. For some patients who have really, mild disease, we only see them once or twice during pregnancy. And for some people who have more serious conditions, we will see them once a month. Medication management is really important as well, because there are some medications that we have our cardiac patients on that are not safe in pregnancy. And we want to make sure that we stop those because they could affect the fetus if you get pregnant on them. So talking about stopping them and making sure things are still optimized before pregnancy is really important. And then during pregnancy, we might need to titrate medication. So for example, as somebody that has an arrhythmia and is on a beta blocker, we may need to increase that during pregnancy if we see arrhythmia symptoms or arrhythmias manifest. And then I mentioned a very important part of what we discuss is delivery planning. So typically, if it's possible and if it's safe, we like patients to deliver vaginally. That has a lower bleeding risk. It's better for the fetus and better recovery for mom. So there's some nuance to that because some conditions are too high risk to deliver vaginally. So all of that we discuss in our multidisciplinary meeting, the modality of delivery, the timing, and collaboration with our anesthesiologist about how to do it. This is something called a CARPREG risk score, which is one of the risk assessment tools that we use to evaluate cardiovascular risk in pregnancy. And it basically assigns points for the highest risk conditions, the conditions that are associated with the highest risk during pregnancy. And then you can sort of sum a score and assess your percent predicted likelihood of having a cardiovascular event during a pregnancy. So you can see here, if you've had prior cardiac events, that's going to put you at high risk. If you have baseline heart failure symptoms, particularly at rest, or if you're hypoxic at rest or cyanotic, that increases risk. Mechanical valves are risky because patients are on anticoagulation, and without that are at high risk for blood clotting, which we sort of previously learned is high risk during pregnancy and with estrogen. And then there are other conditions that are more moderate risk that can increase your risk score. One of the things I wanted to point out here down at the bottom is something that is within our control, and late pregnancy assessment is associated with higher risk. That makes sense because if we're not able to see you pre-pregnancy or early pregnancy, we might not be able to optimize your condition. And so I think that I just wanted to highlight that piece and give the message that coming to see your doctors early when you're thinking about pregnancy, not later during pregnancy, is really a key piece of us ensuring success during the pregnancy. In this risk model, cardiac events were anything from maternal death to arrhythmias to heart failure, blood clots, myocardial infarctions, or vascular dissection. When is the appropriate time to meet with your providers? I would say now. It's never too early. And just like, sort of we heard about earlier talking about transitions, this is something that you want to bring up early and often. So even if at the first discussion you say, I'm not thinking about becoming pregnant now, but sometime down the line I do want that, then that opens up the conversation. So we can give a little bit of anticipation. What will we need to do as we get closer and closer to the time that an individual wants to get pregnant? And the things that we would talk about are things like pregnancy risk. When is the right time? And how can we optimize health prior to conception? We want to screen for other risks, factors, or comorbidities that we might be able to manage a bit better. Things like obesity, diabetes, high blood pressure. And then that gives us a time to do pre-pregnancy testing if we need to. Sometimes that involves a stress test or cardiopulmonary exercise testing, cardiac imaging like echocardiograms or cardiac MRI or CT. Some of those things we can't do during pregnancy. So if we need them, we want to do it pre. And then we talked a bit already about medications and kind of the optimal timing. How do you get connected with us at the McGee Women's Heart Program? We see some patients by self-referral, so please feel free to reach out to us. This is our scheduling number. You can also request an appointment online. And then through your current doctors, we love communicating with people's doctors and making sure that we see people at the appropriate time. We will work people in. So, pregnancy is time dependent. It's not the kind of thing that you can wait 6 months to see the first available provider. So we understand that at the McGee Heart Center. And if you talk with our schedulers in our front office desk, we will often add you on to our schedules to make sure we get you in that time appropriate setting. On this slide, we already talked a bit about how important it is to come and see us pre-conception. In this slide, I wanted to also show that the 4th trimester is an important time too. So classically, we think of 3 trimesters of pregnancy, but after delivery is important as well. And we will often see symptoms manifest at that time and up to 1 year postpartum. To highlight that, this figure shows when we can see 2 specific complications, cardiac complications of pregnancy, arrhythmias and pulmonary edema. You can see in the blue, the arrhythmia likelihood is the number of events are highest in this 2nd and 3rd trimester. That makes sense from what we know about the physiology, because that's when we're going to see the biggest change in need for cardiac output. And so that can manifest cardiac symptoms during pregnancy. But pulmonary edema or heart failure is commonly seen, if we see it, it's going to happen in the 3rd trimester or after delivery. So you can see in the red, kind of the red bar is high in that first 1 to even 6 weeks postpartum. Why is that? Well, if you consider after delivery, you've delivered the baby and the fetus is, the uterus is now sort of clamping down. So we see a whole bunch of fluid re-enter the maternal circulation at that time, and that can promote the development of heart failure for people that have underlying cardiac conditions or who are prone to develop heart failure. So really, really important to be monitoring for symptoms after delivery. What do some of those red flag symptoms look like? Things like chest pain, shortness of breath with laying flat or orthopnea, lower extremity swelling, tachycardia if you're passing out, headache, visual changes can be a sign of preeclampsia, and then certainly fluctuations or changes in blood pressure, whether that be low or very high. I want to give this figure as a conclusion slide, and it's from a Jack article on team-based care of cardiovascular disease and pregnancy. And this model of care goes from preconception to postpartum to long-term. So we really think about almost like an individual's whole lifespan, and pregnancy is one piece of that, but we want to prep for it prior to conception. We take very close care during pregnancy through multidisciplinary team management. And then postpartum too, we want to see you, we want to be monitoring for symptoms and optimizing medications and ordering testing if we need to. We can't do this in a silo. It really takes a village. So as cardiologists, we can't do this alone. And it's the same for the other subspecialties too. We have to partner together with the obstetricians, the maternal fetal medicine specialist, with the anesthesiologist. It takes a whole big team of us. So thank you. And I'll take any questions as part of the panel.
All right, good morning, everyone, or almost afternoon. I'm Orquídea Torres, and I am faculty within the Division of Adolescent and Young Adult Medicine, and I'm here today to talk to you about gender and sexuality. So you may question why I have this slide up, Spider-Man Into the Spider-Verse. I don't know who has seen it, or if you have seen it already, but not to give too many spoilers, this movie was released a couple years back, and it talks about or goes over the main character, Miles Morales, who gets bit by a spider and becomes Spider-Man. But in the process of this movie, Miles has to essentially decide whether he's going to become Spider-Man or not. And a lot of that has to do with whether his parents are going to accept him, his friends and other people around him are going to be okay with him becoming Spider-Man. And in this scene right here, he is taking the leap of faith because now he identifies as Spider-Man and fully takes on that role. He also finds out there are other spider people in the Spider-Verse. Now, fast forward to just a couple of weeks ago, Spider-Man Across the Spider-Verse was just released. And in this movie, Miles obviously already identifies as Spider-Man, but he finds out there are way more spider people than he ever knew about before, which are in the background of this picture. There are spider women, spider men, spider animals, which you would have to see the movie if you want to get a better understanding what I mean by that. But in both movies, what they're hinting at and why I like it, even though it doesn't really bring up the concept of gender and sexuality, it does bring up a concept that all our young people have to deal with, which is figuring out who they are, figuring out their identity, figuring out what they want to be, who they want to be, and who they want to be perceived as. And that is a process all our young people have to go through to and achieve to complete adolescence. But when we think about our gender diverse youth, that process is complicated by all these other stressors that we see on the slide. They are trying to figure out their identity for themselves and internally going through that. But then they have family members, maybe even school members, peers, who may also add to the stress and increase their the impact on their mental health. But we know that when our gender diverse youth are supported, their mental health is less impacted. And so why is this important? So I just want to dive a little bit into the prevalence of gender diversity. And so when we look at a study in 2017 that looked at young people across the nation and how they identified, we see that about 2.7% are identifying as transgender. But that seems like it's underreported, because in 2020, our former fellow, Dr. Kidd, did a study in our fellowship program looking at data across the Pittsburgh public schools and found that about 9% of of teens are identifying as gender diverse. And so it also depends on what the kind of questions you're asking. And so to better understand how this is impacting our young people and how to better support them, let's dive deeper into the definitions of sex and gender. And so we're going to talk about sexual orientation and attraction, sexual development, gender identity, and gender expression. The term sex refers to the binary classification of male or female, and this is usually assigned at birth based on the external genitalia. The term gender, while it's can be changed for or often changed for sex, it really refers to a person's internal sense of behavioral or psychological or social traits. Sorry. And then gender identity is a person's internal sense of being male, female, both, neither. And gender expression is how they show themselves off to the world. A way to really depict this is the flying gender unicorn, or you may have seen the genderbread person, and it goes over all the details of what we're going to talk about. Sexual orientation and attraction, who and what we're attracted to. So sexual identity is describing a person, how a person identifies as. So that can be lesbian, gay, straight, queer, and then their behavior is who they're intimate with. And a person's sexual identity does not correlate with their behavior. So for instance, a person can identify as lesbian but have male partners. Sexual orientation and attraction. People can be attracted to one gender or more than one gender. They can be attracted to certain traits like intelligence or kindness. And the type of attraction can be different, doesn't necessarily have to be physical. It can be emotional or romantic. And then sexual development and biological traits. So we mentioned this earlier about the female and male identification that's assigned at birth, but there are people who are born in this intersex category where they have ambiguous genitalia. And for gender diverse people, they do not want to be defined by their anatomy. And this is just another depiction of that, particularly in the intersex category, where there's a continuum of biological traits. And so a person may not necessarily fall into the typical female or the typical male. Gender identity. So we mentioned this earlier, but a gender identity is an internal sense of being binary, which is male or female, or non-binary, a mix of masculine and feminine, or neither of these. And because this is internal, one's gender identity is not visible to others, and so it's important to ask. Cisgender, that person identifies with the same sex that they were assigned at birth. Transgender is different, they identify with a different sex that they were assigned from birth. And this kind of encompasses all the aspects, with whether it's trans men or women, agender or non-binary, or a mix of that. And then non-binary can include or exclude elements of masculine or feminine gender identity or expression. And they may or may not identify as transgender. Some other terms, genderqueer, this is kind of similar to non-binary. Gender fluid means that a person's gender identity is not fixed in one realm, whether it's a trans woman or a trans male. It depends on how they're feeling and what they're going through at the time and how they want to present. And then agender, kind of also similar to non-binary, where they're not identifying with male or female. To give a better depiction of what that looks like on a graph, this is an XY model, and it shows where the binary identities are on the scale, but also where the non-binary identities are. Another depiction is the transgender umbrella, and this shows you the binary and the non-binary. And so when patients come to us in adolescent medicine, a lot of times they're coming because the way they identify becomes a problem with how they're feeling and what they do on a day-to-day. So an example would be if a person is identifying as trans male, but they have periods, they may want to come and see us because they want to get rid of the periods or do something to help with the periods so that they don't have to deal with that because it's impacting their mental health and other things around them. Gender expression. So this can be different. It doesn't really matter whether they identify as a certain gender. They may want to dress a certain style or present themselves in a certain way. And so again, it's important to ask what a person identifies as because it's not necessarily what's in front of you. So you can't necessarily assume that a person identifies as male if they dress as a male. And then gender transition. So this is some of the steps that we do in our clinic to help a patient and their family feel better and improve their mental health and their goals for their future. And it is a conversation. Sometimes it's many conversations with the parent, with the patient, and having a team, our social work team, our therapists. Sometimes we need psychiatrists. And the adolescent medicine doctors, and maybe even other doctors to help kind of decide what can be done to help with this patient. And the patient also has a lot of say in this and what they are comfortable with. And so for some people, they just want to do a social transition. And that can be just changing the way they dress, changing their hair, or the way they speak, which is reversible. For others, they want to consider doing a medical transition. So one example is using a puberty blocker like Lupron, which can block the effects of puberty, especially if that is making a person stressed or feeling anxious or depressed, that they're going through puberty in a body that they don't identify in. And then a person can also consider gender affirming hormones like estrogen or testosterone to help really align with their identity. And again, that's a conversation with patients, with parents, and the providers all taking care of this patient to decide when we do that. And usually that's an older teen. And then we go forward from there. Surgical transition, this is more complex than it seems on this slide, but again, this is for older teens, young adults who really want to proceed with further steps to align with their gender identity. That may be top surgery, that may be bottom surgery, facial surgery, or voice surgery. And finally, I want to talk about how we treat these patients and teens and young adults when they come see us in clinics, in hospital settings, and other settings in your day-to-day life. So you want to find out their chosen name. So for instance, my name is Orchidia, but my chosen name is my nickname, which is Kiki. And that goes for anyone. Doesn't matter if they identify as transgender or not. It's important to ask what a person prefers to go by. Ask about their pronouns. Again, this is not something that where you're going to know by looking at a person. So you want to ask them either at the beginning of a visit, or even if your staff is able to get that information in the beginning in the front desk, if they're willing to share that information. That's important to know so that everyone can call that patient by their preferred pronouns. And then if you misgender, it happens, and yes, it's a mistake, but you want to correct yourself in the moment, apologize, and move forward. If we dwell on that or we make a big deal on it, especially in a visit, that can make the young person feel even more upset or hurt by this. How do we support a young person? So when they come to see us in adolescent medicine, again, we find out what they like to be called, their pronouns. We like to know what they want as their goals for the future, and what they want to do to be able to get to that point. Who's supporting them? Who can we help to get support for them? A lot of times, again, those visits can be multiple visits in a row, kind of talking to the parents alone, talking to the patients alone, talking together, and involving other providers in their care to help that patient. And then educating parents, you want to provide support for them too. They're going through a lot too. They may be confused, they may be angry or upset for whatever reason, and you want to hear those concerns. So it may mean pulling a parent to the side and talking to them, and it doesn't matter what office or specialty you're in. Depending on if a parent wants to talk about that or if a patient wants to talk about that in a different setting, you can, or refer them out to a different specialist who's able to handle that. And finally, to make an office friendly, LGBTQ friendly, you can train the staff, make it a safe zone for patients and families. And we said this before, but asking about names or pronouns, having signs that show that we are accepting in our clinic space or office space, and asking permission, whether this is okay, it's okay to say these pronouns or say these names in front of family members, patients, and other people. And with that, I will conclude.
I think the biggest thing, I'm a subspecialist, as you all know, and I think that a lot of my colleagues don't ask questions about sex, gender, sexual reproductive health, concerns or goals, because they don't know what to do with the answers. It makes people squeamish. And they say things like, well, I don't ask that, I don't want to open Pandora's box, or I don't want to say I don't know. And I wanted to get a sense from your perspective, both on the adolescent medicine side as well as the subspecialist side. How do you approach that, and like how do you rely on resources within our hospital system to get around those situations where you don't have the expertise?
I can start. So I think it's important to find that out for everyone, because these patients are going to show up in any specialty clinic, not just adolescent medicine. And if you know what they like to be called, what pronouns they like to use, they can feel better respected in that setting with you, even though you do not do that type of care. Now, if you bring that up and you ask that question, and then you feel like you're going down a rabbit hole, you can say, hey, this is not my expertise, but I'm willing to, and I want to help you, I'm willing to help you, and so I want to refer you out, if you want that, to specialists that can do that for you. And you can definitely see them and still see me for ongoing care for various concerns.
I think we take that approach on the subspecialty side as well, and I really appreciate that question, because cardiologists generally are not well trained in talking about contraception or talking about pregnancy or gender issues. Cardiologists really feel uncomfortable. So the approach we've taken in cardiology is to try to educate our peers. So we talk about these issues at our conferences that span UPMC, like across, multi-state. Because it has to be universal. We really feel strongly that every cardiologist needs to feel comfortable with at least opening the conversation. And similarly, if they need, more advanced cardio-obstetrics care or approach, then we see them at McGee. So we'll very often, see people at McGee during their pregnancy, a little bit postpartum, and then we'll transition them back to their kind of general subspecialty providers.
Yeah, I agree. I find a lot of benefit of explaining to families the first time I meet them that I'm going to ask to see the adolescent or young adult alone, because I think that's a huge piece that seems so straightforward, but a lot of us forget to do. I think also, just kind of, as I mentioned in the talk, is really just trying to get a sense of open-ended questions, like what are your goals? What are you struggling with right now? What's difficult for you? You're not going to be able to address everything at every clinic visit, but I think really just being open-minded and finding ways to work these topics into their set of goals are important. All right, thanks, guys.
Thanks, everyone, for the wonderful breakout sessions. We'll hopefully people have come back into the main room now, and we'll be going straight into our keynote speaker. We'll just give it one more minute for us to set up, and then we'll get started. All right, everyone. Thanks for sticking around, and this is the highlight of our conference. It's my great pleasure to introduce my dear friend, Dr. Adrian Kovacs, as the keynote speaker for this conference. Dr. Kovacs is a Canadian psychologist who has worked as a clinician, researcher, and educator in the field of adult congenital heart disease for over 20 years now. She is the past president of the International Society of ACHD, and she was the first non-physician to hold this position, which is a great honor. Previously, she was professor of medicine in the Division of Cardiovascular Medicine at Oregon Health State University. She has chaired the 2022 American Heart Association Scientific Statement on Psychological Outcomes and Interventions for Individuals with Congenital Heart Disease, and was a co-author on the 2011 and 2022 scientific statements on transition in congenital heart disease. Last year, she launched Equilibria Psychological Health with dual focus on psychological well-being of both adults with heart disease as well as healthcare professionals. Dr. Kovacs, thank you.
Thank you for that introduction. I'm going to screen here. I can't see the book. Can you see this here?
We see your slide deck. We do not see the presentation.
Yeah. And now I think do I need to swap it?
There we go. There we go.
Hang on a second. It went to the first one. Sorry. Okay, do I need to swap it? Do you see my
We see it.
So do you see my preview slide also?
No, we just see your presentation.
Okay, good. Okay, good. Sorry about that. Well, good morning, everyone. It's a pleasure to be here with you today. I'm actually doing this from Montreal. So although I'm a Canadian and I primarily live in Toronto, I'm in Montreal for the summer. So bonjour, everyone. So as I was getting ready for this, first of all, I'd like to thank Arvind and Andrew for the invitation. And I was looking back and I realized that the first presentation that I gave on transition was in 2007. So Gary Webb had invited me to speak at an ACHD conference in Philadelphia. And I was thinking about how my own perspectives on transition have changed since that time. So I think many of us who have been working in this field for a long time will maybe describe a transition to transition, if you will. I practiced in Toronto for 11 years. And as Beverly described, I worked really closely with the Good to Go program, the hospital-wide transition program at Sick Kids that actually is no longer. And I worked closely with Miriam Kaufman. And in Toronto, as in many places in Canada, we actually have mandatory transfer at the age of 18. I also worked for almost 6 years in Portland, Oregon, where we had a flexible age of transfer. And in both places, we established a transition task force comprised of both pediatric and adult providers. And even now, although I've left formal academia, I'm still engaged in research focused on transition. So right now, most recently, we've been developed and have been evaluating an app that we developed for transitioning youth, both with brain-based disabilities and congenital heart disease. And I mention this because transition has been an issue very close to my heart for over 15 years. And I have no disclosures. All right, so to begin, when I was thinking about putting this presentation together, I really hoped that attendees would leave with improved knowledge and practical skills. So I hope that by the end, people will be better able to describe why we have a collective responsibility to improve the transition of youth with special healthcare needs from pediatric to adult care, and really using congenital heart disease only as an example. And also, I hope that people are better able to apply strategies to improve transition experiences and outcomes, and really within a team-based approach. And that's one of the things that I'll emphasize today. So I think that transition is a very important opportunity to improve the lives of individuals born with congenital heart disease and other special healthcare needs. And I just wanted to include one slide because I realize that not everyone will be familiar necessarily with congenital heart disease. So this is a figure taken from a scientific statement that we published last year looking at psychological outcomes and interventions for congenital heart disease. And I use this figure to really convey the journey that people with congenital heart disease face. So there are many potential psychosocial stressors that are common and really understandable along the timeline, and transition is just one of them. So even beginning in the prenatal period, so oftentimes there's an increasing proportion of people who are diagnosed even before they're born. They can face challenges in the intensive care units, early family life as they're developing their identity, education, early peer interactions. And transition is something right in the middle there. And this is something that affects every one of our patients. So not everybody will have difficulties with education. Not everybody will have traumatic healthcare experiences, but all of our patients that reach adulthood will have some form of transition. And if we follow along this to the end, as James mentioned earlier when sharing his patient experience, there absolutely is a transition to older age also. And I was thinking as James spoke, and I reflected that many of the patients that I've worked with, they have described living with congenital heart disease as a part-time job for which they never applied, but they say it takes up a lot of effort. And this part-time job does not pay them, and that they actually have to pay financially with time, other resources to keep this part-time job. As mentioned earlier, transition is a process and transfer is an event, and sometimes they're used incorrectly interchangeably. Just going back to this definition that I think Andrew shared earlier, transition is a purposeful, planned process that addresses the medical, psychosocial, educational, vocational needs of adolescents and young adults with chronic physical and medical conditions as they move from child-centered to adult-oriented healthcare systems. And I really see two distinct aims of transition. The first is continuity of optimal healthcare across the lifespan. And what that means is that we avoid lapses in care, or this expression that we often use, loss to follow-up. I prefer the term lapses in care, by the way. And this isn't easy because this depends upon a patient being informed about the importance of lifelong healthcare. It means they agree that it's important and worth any discomfort or inconveniences, and that they are able to access it. And the second aim is that we help youth develop the knowledge and self-management skills to assume maximal responsibility for healthcare management and live as full and independent lives as possible. And I emphasize words like maximal and as possible here for a few reasons. I think this is one area that I've shifted my thinking on transition over the past several years. I think when I began, I thought, okay, by the age of 18, we got to get everybody ready to do things on their own. And I think that we now realize that it's an extended process. But also, particularly if we're thinking about health conditions like congenital heart disease, where there's an increased risk of neurodevelopmental deficits, delays, and disabilities, not everybody will be able to assume full responsibility in adulthood. So the goal is to work with each individual patient and figure out for them as an individual, what is the maximal responsibility that we can help them develop so that they have as much influence over decision-making and responsibility in their lives as is possible for them. I very much consider this as a timeline approach. And in the discussion earlier, I think there was a question about when we begin transition. So I see this really as an extended process. So beginning in childhood, even at birth, parents can be prepared for their children with congenital heart disease or another pediatric onset health condition to become adults with that condition. So I like when I hear parents asking questions about what's this going to be like for my child when they grow up. Beginning by 12 to 13 years of age, patients can be helped to gradually develop knowledge and self-management skills. With regard to transfer, guidelines recommend a flexible age of transfer, ideally between 18 and 21. So the 22 years in the transplant program that was described really well earlier, that sounds like a fantastic program, very reasonable. Again, it's different in Canada. So most provinces at the age of 18, you cannot be admitted or seen in a pediatric hospital. And then there's this idea of emerging adulthood. And what this means is between 18 and 25 years, these knowledge and self-management skills continue to develop. And in emerging adulthood, we really see this emphasis on decision-making and responsibility. And what this means is that we really need to think about collaboration of pediatric and adult clinicians. So transition isn't something that we can allocate solely to the pediatric setting. Well, how are we doing so far? So how far have we come in the 16 years since I first gave a presentation? Well, going back even farther, here are some key documents that were released about 20 years ago. So something from the, a nice summary consensus statement from the American Academy of Pediatrics from 2002. There was a statement I referenced earlier from Society of Adolescent Medicine from 2003. We also had a Canadian consensus statement in 2007. And so 10 years, almost 10 years after publishing the first document, the American Academy of Pediatrics released a follow-up statement. And they noted that after nearly a decade of effort, widespread implementation of health transition supports as a basic standard of high quality care has not been realized. Not much happened in that decade. But what about congenital heart disease? Are we any better? Well, in 2011, we published the first scientific statement from the American Heart Association focused on best practices in managing transition in congenital heart disease. And at that time we wrote, we acknowledge that the development of ideal transition programs is a laudable goal that may not be achievable in the current healthcare environment. And I will say that as an author on that document, I wish we had not included that statement. We gave everyone an easy out. We said, this would be good to do, but maybe it won't be realistic. If you know anything, I would say that in the past dozen years, the healthcare environment certainly has not become more amenable to investment in transition. And just last year, we published a follow-up statement. So again, here, advances in managing transition to adulthood for adolescents with congenital heart disease. And we noted that since the 2011 scientific statement was published, efforts have been made to include transition programming as part of pediatric congenital heart disease programs, but there remain significant challenges to successful implementation. We have not succeeded. So we have great documents and statements explaining what we do, but I think we've earned a failing grade in most places when it comes to the implementation. So let's talk a little bit about lessons that we've learned from congenital heart disease. So first of all, when we think about that initial goal of retention in care, this study was published, 10 years ago now, and it's the Heart ACHD trial. So Health, Education, and Access Research Trial. They enrolled almost 1,000 patients from 12 American adult congenital heart disease centers, and they were recruited at their initial visit in the adult setting. And they completed surveys about gaps and barriers to care. And they found that 42% reported gaps in care of 3 years or longer, including over a quarter with severe forms of congenital heart disease, And the median age at first gap was right about 20 years. So when do these lapses begin? Because we often will focus, as that last study showed, that we really need to focus on retention and care around the time of transfer. So here's a study, and it is a great study, and it's an old one, but we still refer back to this, and it's from the Quebec Provincial Physicians Claims Database. And they enrolled individuals born in 1983 with congenital heart disease diagnosed before the age of 6 and who were alive 22 years later. And they investigated outpatient cardiac follow-up as well as any contact with the healthcare system. And they found that only 39% had cardiology follow-up after turning 18, but 93% did have some contact with the healthcare system. So for most of these people, they were not absent from healthcare altogether. And I should mention that this project was led by Andrew Mackey, and he was a fellow in Montreal at the time. He's now in Edmonton. And I would say that he puts out some of the greatest, really strong research in terms of transition interventions in congenital heart disease. And he's still he and I still are very close collaborators. And this is the interesting figure from this research from the Quebec Physicians Claims Database. So they started with 643 patients who were diagnosed with congenital heart disease by a cardiologist under the age of 6. And then we can go across age categories. So by the time they were 6 to 12, fewer than 2/3 were seen by a cardiologist. So the pink refers to attrition, people who were lost in that age category and never seen again. The yellow refers to people who were absent in that age category but appeared at a later one. By 13 to 17, fewer than half of the people, these patients, were seen by a cardiologist. And then, as mentioned earlier, that decreased to 39% in the 18 to 22 category. And the important takeaway message is this: if we wait until patients are 16 or 17 to start talking to them about the importance of lifelong care, we will be too late. So why do patients say that they have these lapses in care when we ask them? They describe a variety of reasons, including that they're feeling well, they didn't know follow-up was required, some of them were specifically told that follow-up was not required, they don't know where to go, they were discharged from the pediatric hospital without identified adult congenital heart disease clinics. Some of them have a complete absence from medical care, there's a lack of insurance or inadequate insurance. And some people are absent from care due to psychological reasons. So they are fearful of receiving bad news. So we know that retention in care is a problem in congenital heart disease. Well, what about knowledge gaps? So just to share a couple studies with you, this first one is from 2010. And this was done this is in the Netherlands. And they asked several questions. And we can see here that only 45% could describe the name of their heart defect. So less than 1 in 2 patients could actually describe the name of their defect. And still fewer knew the importance of follow-up, what to do if they have side effects for the medication, or what endocarditis is. And this study was just published in 2023. And so in this study here, this was done in London, England, and they did an intervention. They studied people who had attended transition clinics, and they enrolled almost 600 people. And the 3 bars on the left are patients without learning disabilities, and the 3 bars on the right are for people with learning disabilities. And they call it Ready, Steady, Go. And those are just the first, second, and third clinic visits. And if we look at the Ready on the left without learning disability, so at baseline, when they're about, I think it's like 15 or 16 years old, we can see that only 40% of the people were fully able to name their heart condition. So they also asked them questions about describing what they had and explaining it. And that dropped to, 20% were fully able, 40% unable, and that dropped to about 10% who were unable at follow-up visits, so through this intervention. But again, most people were not able to even name their health condition, and far fewer people with learning disabilities. So it began at just over 60% were unable. And I mention this because this is something over 12 years that it's still an ongoing issue. So despite efforts that we've been implementing to improve patient knowledge and self-management skills, we haven't really realized, I would say, meaningful change. So let's switch gears now and talk about strategies to improve transition experiences and outcomes within a team-based approach. We have excellent guidelines from Got Transition that were shared earlier. We also have transition documents from NICE in the UK, Canada in the middle, Australia with the beautiful documents on the right. And I would argue that it's really time to move from guidelines to implementation. And when we think of the key stakeholders, as Andrew mentioned in his introductory remarks, the patient absolutely is centered here. So we have the patient in the middle who's expected to, or hoped, so we help to support them to develop and negotiate independence and interdependence. We have the parents or guardians also involved. And in this figure here, I say that we have the pediatric providers and adult providers. And if I were to redo this figure today, I would really focus on the team approach. So this includes physicians, so cardiologists, surgeons, nurses, NPs, PAs, psychologists, social workers, and other mental health care professionals. Depending on the health condition, it also may include occupational therapy, physical therapy, speech therapy. So we really want to think about a team approach when we want to improve transition outcomes. When we think about education in congenital heart disease, there's a lot of information that we wish to impart. We have medical information and lifestyle information. And on the left column here, the two things that I think are really important, if we could only choose two, we want people to know the name and description of their cardiac condition. So if they're on a school skiing trip and if they break their leg and if they show up in the emergency, that they can tell the emergency team, this is the name of this is what I have. This is what you ought to know to take care of me. And we want them to know the importance of lifelong care. There are also lifestyle issues. So physical activity recommendations, education, career planning. I attended, it was a really good breakout session earlier on contraception and family planning. There's a lot of information. We also want to help them learn kind of a long list of self-management skills. We hope that they will be eventually able to speak independently with healthcare providers if they have the ability to do so, to make or participate in medical decisions, to contact health providers, to schedule and attend appointments, maintain their health records, adhere to medication. As a psychologist, I think it's really important that we help them learn how and when to access mental health services, know how and when to access emergency care, and also to understand health insurance matters. And we can do this. So here's a study from Andrew Mackey. We collaborated on this intervention, and we found that self-management and scores improved with 2 nurse-led one-on-one sessions. So during those sessions, the nurses provided individualized patient education. They created a health passport, so a portable health summary. They discussed 3 third-person scenarios. They had videos demonstrating poor and strong communication skills. We had a video about talking with your doctor, and we role-played 2 standardized healthcare scenarios. So 2 interventions made a difference. Sorry, intervention with 2 sessions made a difference. And I'd just like to acknowledge that we expect a lot from adolescents. And so although I'm targeting my presentation more to clinicians, I realize there may be some patients and families in the audience. And gosh, we expect a lot from our teens. This is a period of significant cognitive, emotional, and sexual development. Identity formation is a key feature. From a developmental perspective, there's often a sense of personal uniqueness. So I'm in love, and nobody has ever felt love like this before. There can be a sense of invulnerability. We know that adherence rates tend to be lowest amongst adolescents. And so it's very odd and difficult that the time that we often think about beginning transition is also the time when teens perceive lower vulnerability and are the least interested in talking about their healthcare. And this is another reason why we actually want to begin early. We want to begin in childhood. I love it when I see a 7 or 8-year-old who comes up to me and says, this is the name of my, my congenital heart disease, and I have a pacemaker. So it's great to begin early. And we know that relationships matter when we think about transition. And here was a survey of 257 US pediatric cardiologists, and they were asked about their perceived barriers to care. Number one was the parent emotional attachment to the pediatric provider. Number two is the patient emotional attachment to the pediatric provider. Down at the bottom were attachments to the institution. And I have worked with people in their 30s and 40s who are facing major health events and perhaps the end of their lives. And when they talk and when they think about, what they want to have happen afterwards, they'll often say, I want people to donate to the pediatric hospital. So even though by that time they may have spent more time in adult care, there's this strong lifelong allegiance to the pediatric setting. And if you look at the fifth one down here, we see that there's provider attachment to the family and patient. And I think it's really important to acknowledge that many physicians and nurses have been taking care of patients for a decade or two. So obviously, providers also get attached to patients and families. So for this reason, it's really important to openly address parental concerns. So fewer than half of parents think their child would be ready to take complete responsibility at age 18. I don't think they have to take complete responsibility. We want to help them to take as much as they can. It can be scary for many parents to let go. It's understandable. Parental over-involvement is understanding. So let's thank parents for their continued caring. This should not be something that we pathologize. And it's really important to fully explain the rationale for and risks and benefits of transition. Consistent messaging is essential. And this is where we come back to this team approach. So it's very confusing when patients and caregivers receive inconsistent messaging between providers within the same program or between outpatient and inpatient settings. So we want everybody to be sharing the same messages. We want to avoid deferring transition efforts to a single person. It's okay to identify as a transition coordinator, who's somebody who can kind of rally the troops. But what we don't want is a patient or parent says, I'm wondering about transition, and we say, go talk to that person about this. So this is something we want everybody to be versed in speaking about. It's important to present transition and transfer as natural and positive. So we want to avoid saying things like, I wish I could keep seeing you forever and I didn't have to send you to the adult program. And finally, making a public commitment can benefit patients, parents, and providers and staff. So we can hang signs. So when we talk about investing, signs are pretty inexpensive. You can hang signs that say things like, beginning in adolescence, we transition our patients to become more responsible for their healthcare. It is our standard practice to speak with teenagers on their own for part of every clinic visit. I think this is a really important practice, and we want to normalize it and prepare folks for this. And let's celebrate things. Our patients graduate to adult care when they turn 18 or 22 or whatever is typical in your clinic. So let's celebrate this. We celebrate when kids graduate from high school, and these days we even celebrate it when they graduate from kindergarten. Let's acknowledge this accomplishment. And here are some other strategies that you may wish to consider. So developing the educational checklist, preparing a written transition plan, provide clear expectations and a rationale for practice shifts ahead of time. Consider transition events for patients and families, just like you're doing today. And you may want to have that within your specific team. So when I was in Toronto, each year we used to have a transition event, a collaboration between Sick Kids and the program at Toronto General Hospital. Provide positive verbal reinforcement to patient and families anytime they engage in efforts that are directed toward patient education and self-management skills. So, give a high five when somebody comes in and they can tell you the name of their diagnosis. When you think about teamwork here, we can coach clinic booking staff to speak directly with patients as much as possible. I like the idea of incorporating a 2-visit approach to transfer in pediatric and adult settings. So in the pediatric setting, we don't want it to say to patients and families, okay, this is your last visit. We want to say, this is your next to last visit. So if the next time you come, let us know if there are any last questions that you have that you'd like to ask us. And even in adult care, let's not throw everything at them at once. Let's have the first visit more of a meet and greet, and then maybe getting to some clinical planning the second visit. Incorporate neurodevelopmental and psychosocial information into the transfer letter. Give a personalized transfer summary to all patients, and again, use language to celebrate transition of care. And as a psychologist, I just like to share a few language tips. So when we're providing education to patients or families, instead of saying, do you have any questions or concerns, which is a yes or no answer, say, what are your questions or concerns? Instead of saying, do you understand this information? Ask, am I explaining this clearly? When I talk to patients and families, it's not their job to listen better. It's my job to explain things well. When we think about language to convey compassion, and let's avoid saying, don't worry about this, because in the history of all time, when we say, don't worry about this, people don't automatically stop worrying. Consider things like, I understand this can be a scary or stressful situation. It's understandable it might take some time to adjust to a new team. I'm confident that you can do this. And language to convey empathy. Instead of saying, I know how you feel, say, I've heard from other patients and families that I can imagine this might seem stressful. Tell me what this is like for you. And I will say that anytime we're doing any transition efforts, let's share our work. So this is, by the way, is a website, iheartchange.org, that we initially developed in Toronto, and now we made publicly available. So it really is for youth and young adults with congenital heart disease. There's a lot of information there, and we wanted to make it available. So that's a website you can go to if you like. So we often use the bridge analogy when talking about transition, and I love that your transition event did this today. We talk about bridging the gap from pediatric to adult care. I just like to emphasize that on this transition pathway, there are many different types of bridges, and our goal really is to understand the starting and end points of each individual patient and support them on their journey. So in conclusion, it is time to shift expectations from transition as something that is nice to provide to invest in this essential component of care. We have this collective opportunity to help adolescents and young adults achieve the best possible outcomes and quality of life, and to live as full and independent lives as possible for them. And finally, every member of the team, including clinicians, physicians, nurses, allied health, and administrative staff from pediatric and adult programs, can collaborate and contribute to positive transition experiences and outcomes. And thank you very much. And I am going to stop sharing here. I can see you now. Well, I can't see anybody now, but I can see me now.
Well,
by the way,
Adrian-
if I can just add one more thing, my main regret about not attending, being able to attend in person, is I would have liked to stay for the lunch session. I think you're having clinicians and patients and families. I love that kind of stuff. So I'm really sorry I won't be there for the in-person conversations.
Yes, and Adrian, Arvin and I would like to thank you for giving your time to talk with us and share some of the work you've done and the lessons that you have learned over time. And as we're going to wrap up our time together, we are going to end where we started, and we're going to give it 1 second. And we have, once again, this idea of bridges. And I love that statement that there are many different types of bridges, and that we have to be able to look at it uniquely for every patient, every family, and how they do that process. I'm going to give a real quick summary of where we've been today, because we have been going on a journey around transition and heard lots of different perspectives. And so if we could, am I in charge of this? Nope. Can you go to the next slide? The what? Oh, perfect. Look at that. One thing that we learned is that timing is important, right? And one of the issues often around transition is that it occurs too late, the transfer leap. Someone ages at a transition age, 18, 21 years of age, and they feel like they're gonna have to cross this chasm on their own. Or as we've talked about, that there's a lot of different transition tools, and yet transition sometimes is done incompletely. And so often our young adults and our families feel like they're left to come to navigate this on our own. And hopefully one of the things around timing we've heard over and over again is that transition needs to be longitudinal, meaning it needs to occur early, 12, 14 years of age. And we need to build a great, strong bridge that starts with an on-ramp. How do we prepare our young adults for those skills? Really, the metal crossing the bridge is a short time, and there's an off-ramp that even when they've moved to the adult world, transition isn't done, that we have to make sure that there is safety nets. There's this complication, right? People often confuse transfer, the physical movement from one location to another, with transition, which is that purposeful and planned process to move towards adulthood. And I think that's a really key point that we've highlighted today, and hopefully we can take away. Another key point we talked about is transition's complicated. We often in the medical field think about our side of things, the healthcare portion, but I love that we had speakers thinking about the financial implications and the legal implications. We can talk about educational implications. We can talk about sexuality and gender. We can talk about all these different components. People are complicated. They're not just one thing. And often we do transition in our different silos, right? We don't do a good job communicating. I would really want us to shift our thinking, and why we've done this conference with different stakeholders working together is that transition's really like a puzzle. Each of these different domains is really important, but they also touch each other. And if one of those pieces is missing, it impacts the whole puzzle. So we have to think of people completely. We can't just think and deal with just one part of who they are. So it's really important to have a holistic view of transition. And the final one that we've talked about a little bit over and over again is that there's different stakeholders at the table. And often it can feel like there's a transition tug of war, that people are pulling different directions. The young adult is going for independence. The parents are not quite ready to let go. The adult providers, the pediatric providers are kind of trying to understand their part of this, and it can be really challenging. I'm going to steal the slide. I'm sure, Bev, I was facing the other direction, but I'm sure this is the slide that you were showing, that really transition is this process. And I really like to frame it as a dance. I got my 3 daughters who are sitting at the table back there, and they can probably attest to you that once upon a time we would have dance parties, and when they were young, they thought that I was an amazing dancer. That has changed. But, as a parent, having a dance party with your kids, everybody's having a good time. They look at you and they're learning from you. They like the type of music that you're putting on. But as they get older, they learn what music is important to them. They decide what dancing should look like to them. And we have to give them that freedom. We have to let them start taking the lead. And so really transition is like a dance. We might kind of help and shape and teach them early on, but eventually that's only to the point of giving that away so that they can be the stakeholder, that they can be the CEO of their care, that they can take over. So when we kind of think about this, we want to end with this idea that transition is really equal to inclusion. Transition is about how do we not get people to become adults, because the truth is people are going to get older and they're going to become adults. We want them to go into adulthood, but we want them to go into adulthood in a way which they're also valued. So their perspectives and who they are brings value to all of us as a community. So we talked about this purpose of transition being about equity and about centering those young adults so that who they are can be brought and valued within our community. And I will leave us with one last quote from a famous Pittsburgher, Mr. Rogers. And he said this quote, that transitions are almost always signs of growth, but they can also bring feelings of loss. To get somewhere new, we may have to leave somewhere else behind. And this is so true. And I love Mr. Rogers and some of his quotes. And he highlights that transition is not just one thing. It's complicated, right? That you can't just have one emotion. I love that we celebrate the graduation, that they're moving into adulthood, but it is complicated. There are a lot of feelings held at the same time, and we have to admit that so that we can process and work through it. So let's go ahead and start our journey of transition, and we will end with a little bit of time for Q&A if anybody has questions, that we'll open it up to the audience, and then we can use our collective knowledge to kind of support each other through it. So if anybody has any questions online or in the audience, we're happy to open it up for a few minutes before we move on to lunch. Well, looks like people may just be hungry. So why don't we go ahead and close out? If there's questions in the chat, I'm sure they can pass that on to our team and we can share answers, and we'll be able to have some discussion in the room together over lunch. So thank you everybody for coming here, and go ahead and jump out of the room and grab some lunch and come back here and let's mingle.